Doctors, we are live. You can start the session.
Oh, thanks, Sai. So without any delay, we'll go on to our very interesting session for the next couple of hours, hot debates in cataract surgery. And I'm sure when we look at the topics, we truly realize that these are so relevant to us in our day-to-day practice, and nothing short of the best speakers and the top-notch expert panel to adorn this 2-hour meeting. So let's look forward to good, crisp talks and a great exchange of thoughts and doubts. And I would look forward to everybody putting in their thoughts if time allows. We are truly, truly lucky to have with us our star of the day, Dr. Prema Padmanabhan. And it is such a loss that I lost her in my ARC meetings. Don't even ask me what or why it happened. And we all know she's heads the cornea department, but that she just head that. I think she's one of the main pillars of the Medical Research Foundation at Chennai, and we are indebted to you, Dr. Prema, and we look forward to learning great pearls of practical wisdom from you. Dr. Mohan Rajan would be joining us soon. We all know he's the chairman and medical director of the Rajan Eye Care, and also a past president of Tamil Nadu TNOA and IRSI. And he has there's some award session which is holding him up. We are really lucky, as always, to have with us a great stalwart of ophthalmology, Dr. Jeevan Titiyal, who is professor of ophthalmology of RP Center and heads it, and is doing probably the most wonderful, awesome job in his post now. And we wish him the very best in his career ahead. And we are really lucky to have you with us, sir. And we have with us Dr. Ramurthy, who's the chairman of the Eye Foundation group of hospitals and also our past president of AIOLs. And I'm sure he will come out with his very practical viewpoints every now and then, and we would learn a lot from him. Joining us soon would be, hopefully, would be Dr. Namrita Sharma, who again is a professor of ophthalmology of RP Center and is also our awe-inspiring chairman scientific committee, and we look forward to wonderful work to be done by her in the coming 3 years. Joining us very soon is Dr. Gaurav Luthra, who's caught in traffic, who's again the director of the Drishy Eye Institute at Dehradun, and is another very versatile cataract refractive surgeon, and is also the chairman ARC of the IRSA group. So without ado, and of course, joining me a little haphazardly is going to be Dr. Kamal Arsi, who is a senior consultant at the Cataract and IOL services from the Eye Foundation group of hospitals, and a surgical trainer for all our young postgraduates, and an amazing surgeon. And we shall go on to there's going to be a little shuffling of talks, as both Dr. Jeevan Titiyal and Dr. Kamal Kapoor would have to leave shortly. So we shall start with that last session as the first to go. And Dr. Anurag Mishra has yet to join us. He has not joined us yet. Would it be, should I just wondered if Dr. Titiyal would talk and then Dr. Kamal, you would talk. By the time I think Anurag Mishra would be there.
Yeah.
Okay. He wanted just few minutes to join in. So I'll go on to introducing you all. Just a minute. So this session is going to be an interesting session. The debate concept is, it's a 50-year-old with a clear lens and who wants spectacle independence. And we are looking at the different alternatives which would appeal to a person at this age group to get rid of his glasses. So we have two stalwarts of our Indian ophthalmology, the young Dr. Anurag Mishra and Dr. Kamal Kapoor, who are going to debate on this. And Anurag Mishra is a consultant, cataract, pediatric ophthalmology, squint and oculoplasty, name it, he seems to be doing it all from the Car Vision Eye Hospital, Orissa. And his topic is going to be clear lens extraction with trifocal, the right approach. Sorry, I just missed out on introducing Dr. Minu Matan, who's again that magic luck for me in all my webinars in the last 3 years. And he's a senior consultant cataract and glaucoma services from the Chaitanya group of eye hospitals at Trivandrum and is a surgeon of an amazing repute and has won innumerable awards, not just in the Indian ophthalmology, but at the international level. And I'm truly happy to have him with us as one solid expert panel through the next 2 hours. So Anurag Mishra has also joined, so that's fine. And he is going to be talking on clear lens extraction with trifocals, the right approach. And Dr. Kamal Kapoor, who is the director of the very dynamic group of hospitals, the Sharp Side group of hospitals based at Delhi, but which is spread out all over. His topic is going to be presbyopic phakic IOL could be the option. And moderating them and giving his expert view is going to be our expert panel, Dr. Jeevan Titiyar. So we would look forward to his thought process after the two have done their job. So Dr. Anurag, we go on with your thought about clear lens extraction for a 50-year-old. On to you.
Thank you so much, ma'am. Am I audible and is my screen visible at all?
Yes, yes. Thanks for chipping in early.
Thank you so much, ma'am. Good evening, ladies and gentlemen, and greetings and regards from the land of Lord Jagannath. And the motion that has been given to me, the 50 years old presbyopic correction, a presbyopic patient who needs a correction, I think there is a little bit of incompleteness in this motion, and hence that's the reason why I've added on a few facets which have been clandestine in it. The 50 years old patient who has come to me for presbyopic correction has in all possibilities come to me for diffraction and glass prescription and not for a surgical choice. The moment I introduce him to the surgical choices that are available with me, and the discussion that goes on after that is basically because of the fact that the patient is intrigued more than motivated. And the motivation that needs to be curved into the patient has to be really crafted in. It needs to be curated into the patient. But hang on, is this the patient who needs to be motivated? Well, we'll see that at the end of the 6 minutes duration of deliberation that I have on my side. This story is going to be depicted to you, ladies and gentlemen, in its 3 stages, just like any story. The first stage is the prologue or the preoperative considerations. The main text is the procedural considerations, and then comes the post-operative considerations, which forms the epilogue. This is between 2 procedures which hang in the balance. One deals with disturbing the intact structures in the eye. There is no cataract and we're removing the lens like that. And the other procedure invades the intact space. So let's talk about a few changes that happen in this intact structures which are age-related, and how do they affect this intact so-called space that is going to be invaded by the phakic IOL. Let's talk about the crystalline lens first. Studies show that with increasing age, the axial curvature of the anterior-posterior diameter of the lens increases by 21%. This is one lens which is distant fixated of a young individual. The second picture is the near fixated lens of the same young individual. And the picture down below is the aged lens, which is distant fixated. So the anterior posterior diameter of the aging lens is even more, which is when it is distant fixated, than a young lens, which is near fixated with full accommodation in question. The result, the space with which the PIOL, phakic IOL is being utilized is going to be reduced. So it has more likelihood of brushing against or touching physically the lens and the iris both. There is a light scattering that happens in the aging lens, even without the presence of cataract. And the scattering happens most commonly in the C3 cortical area. The C3 cortical area is the innermost cortical area, which is closer not only to the optical center of the lens, but also to the nodal points. This is without cataract. Add to that the scattering that is, or the reduced contrast that is likely to happen from a ring design of a phakic IOL. The patient's not going to have a very clear or crisp vision. The anterior chamber angle with age reduces to the extent of 0.11 mm per year. Now, to prove this, this is a patient of mine who's 50 years old. Look at the angle dimensions at 500. ACA 500 measures at 27 and 22 degrees. 27 and 22. Remember the numbers. This is another patient who is young and has come to me for ICL. The dimensions in the angle are 38 and 53 before surgery. Post-operatively, the same patient's angle comes down by 10 degrees to 29 degrees. So 27 and 22 in a 50 years old, that angle, it reduces by 10 degrees after you put in the phakic IOL, you are counting an angle of 17 degrees. Big reason to worry. Accommodation. At the age of 50, it is said that the accommodation is really absent, but some of them are left with a 0.5 diopter. So it might be difficult for us to decide the add power that we are giving to the phakic IOL. And if there is a 0.5 diopters of accommodation left, eventually it bears off. Eventually, the patient also has disturbances in his near vision. The spherical aberration, while we implant an intraocular lens, all we have to negate is the corneal spherical aberration, which is around 0.2. But when we are judging the phakic IOL, the total spherical aberration of the total eye as a system has to be taken into consideration. And this negative spherical aberration in the phakic IOL is not enough to negate all that. So the crispness of the vision might not be there, although you might have a good depth of focus. When you consider a trifocal IOL, which of these factors to consider? Practically none. But when you consider a phakic IOL, and which of these preoperative factors to be considered? Well, all of them. Let's go to the procedure part. These are the two IOLs that are in question, the trifocal and the presbyopic correcting phakic IOL. The refractive index has a difference, 1.46 and 1.55. The basic reason is the phakic IOL is hydrophilic in nature. And in that range, we all know that one point decimal difference between the refractive index also plays an important role. The ring design they have created it has less number of rings from 5 to 9. So that's a good job. I'll give it to them. But let's talk about the only study that has been published in here. The pupil diameter reduces after ICL or phakic IOL, and it does not recover even after 3 months. With a trifocal IOL, it also reduces, but it recovers after 3 weeks to 3 months. The reason, the difference between the two is the phakic IOL actually has a mechanical factor for which the the pupil size reduces. So consider a patient driving under mesopic conditions, the pupil is small, the distant vision is going to be affected, which does not happen with a trifocal IOL because there's no mechanical factor. This is the only study that I could find of note where they have studied 8 patients, 16 eyes, and look at the results.
Doctor,
4 weeks after surgery.
You have 1 minute, yeah.
9 out of 16 eyes are emetropic. 9 out of 16. What happens to the rest 7? We don't know. The 40 years old produces a very decent depth of focus curve, but at 48 years old, look at the intermediate vision dropping significantly. This is another curve from the same study, 20/20 or better after bilateral implantation with a phakic IOL goes up to 60%. It goes up to 80% in case of trifocal IOLs. So after surgery, different studies have showed different incidence of cataract formation after phakic IOL, 9.6 to 5.2, but they all agree that it happens. Dr. Mandal also thinks that there is a significant risk of glaucoma following phakic IOL implantation, and some of them actually go on to develop refractory glaucoma. So the conjure of all these factors combined, presbyopic PCIOL is the best choice for this patient, particularly when the power ranges are less than 6 or more than 30, or if the cylindrical dioptric requirement is more than 3 diopters, because trifocal lenses are not manufactured in that level. But the CLE is a better option if you respect the age-related changes in the structures, pre-MD post-operative complications, do not grin at the prospect of multiple phases of earning coming from the same reserve, and do not readily accept based on an anecdotal, fragmentary, and headed evidence rather than scientific one. So, ladies and gentlemen, the motivation that we were talking about in the initial part of the discussion was actually not needed by the patient. It's actually needed by this guy, and who better to provide the same motivation and curate into him than the person who is considered a master in that subject. With that, I must rest and give it to the next speaker to curate that motivation into me. Waiting for your 6 minutes to be over, sir. Thank you.
Dr. Anurag, you are truly wonderful. And Dr. Kamal, you really need to do some magic.
I don't need to do magic. I am magic. So anyway, Anurag, I think it's good you showed the last picture with hands folded and bent down. So I guess that's actually stated that you do need some pumping up and some confidence in what you were saying. Anyway, see, the topic given to me is that phakic IOL also is an option. So I will stand by that. While I do not deny whatever Anurag has said, there are options where a refractive lens exchange definitely is an indication, but refractive lens exchange is the only option or other options cannot be considered. I would like to put my point forward here. So I would just say that, the simple ancient surgical wisdom, and I'm sure Anurag's teachers, professors taught him that do not sacrifice any tissue in any surgical procedure if it can be saved. If you can save a tissue, and if it adds advantage to save that tissue, I would rather do that. So in that particular case, in this particular case, is a human crystalline lens. Now, we have a huge track record of phakic lenses, I think probably highest in the country. And I would disagree with a lot of issues with Anurag probably, but I would excuse it because of his probably a lesser experience with this particular issue. Yes, I agree. You need to be very, very meticulous in your workup, but I'm sure he's very meticulous in his workup for his trifocal lenses also. And that too, if he's operating a clear lens at a 50-year-old man. But if he's rash and it doesn't want to do his angle kappas and his surface disorders and his maculopathies and corneal irregularities and measuring of astigmatism, well, sooner or later is looking for trouble, even if he's putting a trifocal IOL. So similar, but probably a little bit more meticulous workup would be required if I'm planning for a meticulous end result with a presbyopic phakic IOL. Now, you see, efficacy of phakic IOLs has been proven over a decade. The best point in favor of a phakic IOL in a particular set of patients is its reversibility. And I'm sure Anurag will agree with me. Whatever he does with a trifocal lens, he cannot reverse it. At the most, he can explant the lens and put in a monofocal. So the purpose is defeated. Whereas if you put in a phakic lens and by just far outreaching chance, the lens does misreact or the patient is not okay with it, I have the option of doing a reverse procedure. And there is a proven track record with this particular technology. Another thing I must admit is that the availability of high astigmatic phakic presbyopic lenses, and I've done till -5 astigmatism with presbyopic lenses, and my patients are doing fine. Now, where are the issues? There are some times when the patient myself may be having some accommodation. I am 55, and I'm sure anybody can vouch for it. Nobody's seen me wear glasses. And the best part is I'm an emmetropic. I'm hypermetropic in one eye, and I still have accommodation. And let me tell you, there are a lot of 50-year-old plus patients walking around who probably would have some accommodation. So when I go in and take out their crystalline lens, guess what? I'm taking out whatever little depth of focus they had. And then what am I putting? I'm putting a diffractive lens inside the eye. And I'm sure most of us, eyes closed, hearts closed, in closed rooms, talk about halos and glares. And halos and glares with less number of rings are definitely better. And also availability of EDOF phakic lenses with ICL, the Viva series. I've not used any, but I'm getting very good results hearing from my friends. So that option is always available. But let's not forget, number one, I'm taking away whatever little depth of focus the patient has because of his natural lens. If the patient is high myope, I'm exposing him to the chances of retinal detachments. I'm putting in a lens which has got 13 to 15 rings. I'm exposing him to colored halos and glares, and we all admit that these lenses do cause that. And if there is some compensation, because there are some lenses, and I'm sure Dr. Naren would agree with me here, there have been papers published that the inherent crystalline lens a lot of time is offsetting the issues offered by the crystalline lens are taken care by the cornea, and the issues of the cornea are taken care by the crystalline lens by adaptation. So that figure also I'm taking away. And the worst is that the issues of a larger number of rings in a multifocal lens, and not to forget the dysphotopsias, which you may be including. And I can tell you, Anurag, once your patient starts having halos or dysphotopsias, you just have to cut a sorry figure. Well, with phakic lens, you don't have to do any one of these two. And another thing, even if God forbid there's an issue, I can still reverse this procedure. Minimal intraocular inflammations, the complications associated with the phakic lens, especially high myopes. Let's say, very high myopes or high hypermetropes could be tricky. Now, what will happen can happen. So these are the kind of things which can happen if I do an intraocular surgery, removing a crystalline lens. You can have a capsular rupture. You could have endophthalmitis, PC, RAND, bad rexes, decentration of lens, capsular fibrosis, decentration of your multifocal lens, accidental running off of your capsular rexes. All these things can happen. And the number of factors which can go wrong when I'm doing a phakic lens with a trifocal lens probably would be higher than what I would be doing the simple phakic lens, putting inside the eye, lifting, shutting it, locking it, and forgetting it. Now, endophthalmitis is a huge issue. Now, I'm just going fast. The endophthalmitis, younger patients, all these things we need to take care of. A 50-year-old man coming to me with, mild refractive issue, yes, I may want to do a clearance extraction also, but there would be definite indications for me to do a phakic IOL, very high myope, patient not wishing to have his crystalline lens taken away. I just operated a lady 2 weeks ago, two ladies from the same family, daughter-in-laws from a big jeweler in Delhi. One opted for a clear lens extraction and the other one opted for presbyopic IPCL, and both were right. I did not dissuade anyone for them because both had a logic. One said, my lens is working fine, I don't want it out. The other one said, I would rather get it out because sooner or later, maybe 5-10 years, I'll get a cataract. So both are right. So I am not saying what Dr. Anurag said is wrong, but I am saying an IPCL or an ICL or a presbyopic IPCL or a phakic lens also is an option, and you should always have it in the armory, provided you are adept at doing that. And if you have systems and infrastructure in place to have good outcomes. And the best part I said was it's reversible. Thank you. I guess I did it in time and I didn't waste much time.
Yeah, thank you. Thank you very much, Dr. Kamal. That was wonderful too. Dr. Titiyal, we need to learn some pearls of wisdom from you now.
Thank you, Dr. Chitra and Dr. Ram for getting me into this very important topic or discussion or debate. I think both Anurag and Kamal have put their points, and both are absolutely correct in their point of view. Both type of surgeries, if patient is willing to undergo surgery, both phakic IOL as well as for a clear lens extraction, we do have a space for both option for patients. It is up to the us to decide what is suitable for a patient and patient's acceptance. We know that both surgeries will have its pros and cons. Let me start with the IPCL, which has been there for last 5-6 years in our practice. And I also seems to have some long studies on that experience with IPCL. The few important points we look into in these areas for people who are listening to us. Kamal, you can stop your,
okay, so
sharing
just a minute. Yeah, okay.
Yeah, thank you. So I think the important points are to be considered is few. One is age of the patient, because once you look for a younger age group, IPCL may be a better option sometimes because you have a clear lens which is functional. In that, we like to assess two important things. One is the sclerosis happening in the lens nucleus and its effect on the visual symptoms or visual quality-wise. We normally do all these patients two things. One is we look for internal aberrations. Second, we do a DLI in eye trace.
Yes.
If the DLI is less than 5, or if you have a higher internal order aberrations, it's HOA, then this candidate may be suitable for a clear lens extraction more clearly.
Absolutely.
And second, if these two things are all right, if the AC depths are quite good and pupillary diameter is as normal as Indian population, I might prefer to go for IPCL these lenses. It's not that IPCL will not have a visual symptoms, because these are again a diffractive lenses. Sometimes they do have little bit of halo, the pupil is larger. And there we have to make sure the pupil is normally remains normal size. I normally don't dilate these cases subsequent to posterior period, because these lens tends to shift their position with the pupillary size sometimes. So little pupil dependence in terms of especially near distance, they don't really make a difference. Near makes a huge difference. If pupil constricts, the lens position changes, the near vision gets little distorted, but it settles down as the time passes. The bilateral implantation is quite acceptable. I have had few patients who have undergone cataract surgery subsequent to IPCL also, maybe after 1 or 2 years, because it seems that nuclear sclerosis advances quite rapidly in some cases in the high myopic patients, in these group of patients. Cases where we have a difficult anatomy, anatomy, little bit sclerosis, a patient has, little bit of difficulty in terms of the range of accommodation, because that's also very important. What is the reserve you are going to give to these patients? And that's why any patient between 45 to 55, both options are there. Patient beyond 55, I normally tend to go for clear lens extraction as such. I think both the points are well given. As far as complications are concerned, both are intraocular surgery. EDOF can happen to both the groups, but more chances are there maybe cataract surgery. Posterior segment assessment has to be perfect before and after surgery, especially more for a clear lens extraction. But nowadays, we can see so many things so clearly, the chances of increased detachment, other things are going to be less in all surgeries. But I've seen in all my patients where we do clear lens extraction, the PBD induction is much more. The floater incidence is much more with clear lens extraction as such.
So the angle metrics also is
Yes,
something that we should look at.
Anurag,
Yeah.
your point is absolutely correct. If the angle is, you can't go for
Absolutely.
IPCL as such. And
Absolutely.
there we tend to go for a clear lens section. That is one of the major, I think, the recent trend for me also. Any patient with a little shallow chamber,
Right.
and especially female patient, I go for clear lens section in these
Right.
patients.
So I'd just like to add one
wonderful.
point, Dr. Chitra here. I think I agree 1000% with Dr. Tityal. And as I told Anurag, both options are open. And what he mentioned was a DLI. You know, I slipped my head. I'll share something as an anecdote. Samir came to me for doing a presbyopic IPCL for him because he was a myope. And I did a DLI. One eye was 6 on my eye trace, another was 4.5. I said, no, I will not do a phakic lens for you, Samir. I'll do a lens extraction. And he's very happy. So, you know, this is a very important point. For all of us who have access to eye trace, I think this is a beautiful tool for deciding which way the clock swings.
Yeah, DLI, and I think even the lens rise should be taken into account when we are looking at either of these choices. So, Dr. Ramurthy, what I wanted to ask you was, when it comes to these, between the two of them, would you also think of give a preference for a myope or a hyperope in a presbyopic phakic IOL? Is something any of you could answer. I mean, I just thought that DLI, higher order aberration, lens rise. But would we prefer a myope for a borderline situation, a myope we'll prefer, or a hyperope would prefer? Yes, Dr.
For a borderline myopes, you know, these people are very happy with their near vision because they can read without glasses as such. So these patients, you know, sometimes they are in the range where some multifocal may not be, you know, a choice because the axial length may be a little higher. So if you have a good anti-chamber dynamics, I might go for IPCL in those cases because they'll have a, you know, a near vision without glasses. Because myopes, they don't like to use ASUS, you know, glasses. But yes, if they have the range for a trifocal IOLs, both options are open there also.
So would you
Dr. Chitra, can I share a trick which I do? Can I share a trick here for the audience?
Yes.
Like suppose I have a moderate myope. So what I do is I correct their distance vision to emetropia. But in the non-dominant eye, I give them overcorrection in their presbyopic correction by 0.5. And as Dr. Tityal rightly said, they are super thrilled because they can probably get the object a little more. You know, a lot of my critics would say 0.5 does not make a difference. Believe me, I do it. It makes a difference to these patients.
What would be your add correction? Would it be +2 or 1.5?
+2, basic +2. Start with +2. Don't go for 1.5, 1.25. It will not work.
And Dr. Namrata or Dr. Ramurthy, would you believe that it should be definitely the patient should have had a PVD before we think of doing a high myope clear lens extraction?
Yeah, I mean, definitely you need a posterior with a complete PVD, you know, if in case you're considering a clear lens extraction. But I would completely stay away from doing a clear lens extraction in high myopic patients. It might be for moderate myopic patients. Whatever, all chance of retinal detachment is supposed to be less, but still it's not a chance worth taking. I think it was a wonderful presentation by both of them and a great summary by Dr. Tityal, and there's not too much to add except for reiterating a couple of points. The cutoff age of 50 that's mentioned is exactly the cutoff for me, not that I have a hard and fast rule. Less than 50, generally I go for presbyopic phakic intraocular lens. When the patient is beyond 50, we go in for consider more clear lens extraction with a multifocal intraocular lens. The second point, of course, being the kind of refractive error that they have. Because many of these hyperopes, as Anurag very nicely pointed out, already have shallow anterior chambers, smaller eyes, and there is a greater crowding of anterior chamber once you put these phakic intraocular lens. So in these cases, I would tend more towards putting in a phakic intraocular lens, while in case of low myopes, maybe, of course, as Tityal said, many of them don't need any correction at all. If at all a moderate myope needs, you know, nowadays there are patients mothers of May smile patient who says, what about me? Can you do something for me? And she has a -3.5 or 4, and she's 53, 54 years old, and clearly her lens is absolutely clear. Then we can consider putting in a presbyopic phakic intraocular lens. And I think all of them emphasized about the importance of DLI. Anything less than 5, I would also tend to go towards a clear lens extraction. And apart from the currently available presbyopic IPCLs, we recently were exposed to the EDOF ICL platform. And once that comes in, well, mind you, it's not just the number of rings, but both of them are diffractive lenses, whether it's a trifocal lens or whether it's a presbyopic IPCL. But I think the EDOF lenses are likely to be slightly better. Maybe the near vision is not, from whatever we heard about the presentation, near vision is not going to be as crisp as what you find with the trifocal presbyopic IPCL. But then they're going to take care of, like most EDOFs, they're going to take care of intermediate vision and to some extent a near vision. And most importantly, for those of you who might consider putting a presbyopic IPCL, the power comes right from basic power from 2 to 3.5. The whole problem is presbyopia is a dynamic process. What you put, the patient requires at the age of 42 is what he or she may require at the age of 55. So basically, I place, whenever I'm using a presbyopic IPCL, I put in a +3 diopter lens in one eye and +2.5 in younger patients. A +3 gives you only +2 for near and +1.2 for intermediate. And that's the least these patients require. Going less than that may not really meet their needs. That's my just 2 cents about this.
Thank you very much. Thank you, Dr. Tityal, and thank you, Dr. Kamal. I knew you had your issues, and I would want Dr. Tityal to stay with us till his time, which he promised.
Thank you. Thank you, Dr. Chitra. Thank you, everybody. I'm sorry I have to rush somewhere, someplace important. Thank you.
Thank you. We have to include Dr. Vardhaman's group next, because he also has a webinar starting at 7:30. I'm sorry for these small changes, but I think all of us should enjoy all these very interesting talks. And this session is going to be, the second group is post-laser vision correction. What are we going to do? And we have dealing this controversial issue, Dr. Vardhaman Kankaria, who's a young, dynamic, smart cataract refractive surgeon from Asian High Hospital, Pune, and is also the chairman scientific committee of MOSCON. And we are all going to be experience the fantastic way he's going to go about it. And all the best to you, Vardhaman. We really look forward to a great meeting there. And he is going to be talking on monofocal would work best. Countering him is going to be Dr. Vijay Kumar, who's our senior consultant cataract, medical retina and glaucoma services at the Eye Foundation E Road. Vijay, your face is not being seen. Somehow it's a blank there. Adjust your lighting. And he's again another very versatile surgeon. And he's going to be talking on why not trifocals. And we have Samresh Srivastav, who's again another very prolific surgeon, who's a consultant ophthalmologist at Raghudeep Eye Hospital based at Jaipur, and is doing a wonderful job there. And he is going to tell us why not EDOF. So we are going to fight with monofocal, and we are going to fight with trifocal and with EDOF. And we have Dr. Ramurthy to give his expert view for 5 minutes. So everybody stick to your 6 minutes, and Vel Murugan will give you a warning at 1 minute. So on to you, Dr. Vardhaman. Let's hear from you.
Thank you, ma'am. Ma'am, am I audible? And
yes.
The slide is... 1 second. Yes. So first of all, thank you, ma'am, for the kind invite. And I'm going to talk to you about why I believe that the monofocal lenses work the best post laser vision correction. We all know that when the baby boomer generation came and who have actually experienced the first wave of LASIK with the older generation LASIK procedures, which had broad beam lasers, probably not appropriate pupillary tracking systems. But of course, these are the first people who were exposed to the magic of LASIK. These people have relatively like intolerance for diminished vision, and they are the ones which are coming in for cataract surgery now. They demand as good as outcome as refractive procedure from their cataract surgery as well. So what the patients desire today. The patients who are undergoing cataracts desire an accurate refractive result. They desire, of course, a great quality of vision, and they desire a stable and non-fluctuating vision. The issue with the laser vision correction is that it is, especially if you're going for higher optic lenses, such as multifocal lenses or EDOFs, is the unpredictability of refractive results, the added higher order aberrations of both LASIK and this higher optic lenses, and the pre-existing dry eye, which also is going to become worse with age. These three things, they confound and give rise to unhappy patients in majority of these patients, not in all of them. Therefore, I'm going to stick to monofocal lenses for vast majority of these patients. So basically, we all know that in patients who desire this most accurate postoperative refractive errors, these IOL calculations are unfortunately less predictable. And there are three errors that we look at. I'm not going into the details of them. First of them is called as the instrument error, in which you know that the keratometers of today are actually looking at the paracentral points and not actually and missing the central location. The second one is called as a refractive index error, because the ratio of your anterior curvature and the posterior curvature is considered to be fixed, and post laser vision correction that is going to change. So if we don't consider the posterior surface of the cornea, we are going to land up in hyperopic shift or hyperopic surprises, post laser vision correction IOL formula errors as well. And the third one is called as a formula error, because we all know that the current formulas that we are using, which depend on the prediction of the effective lens position, they become erroneous because of the change of the corneal shape. And these errors altogether give rise to a final hyperopic surprise post-refractive errors. We all know that whether it is EDOF or multifocals, they all perform the best in an immetropic optical situations. All these modifications that we have come to, there are a lot of newer advancements which have come with the IOL formula, especially with the help of double K, Aramberry's method, Sharma's method, Hagues-L, and Barrett's true K formula. Now, many of them are clubbed together, and that is seen in the ASCRS formula on the ASCRS website. But in spite of all these things, a lot of studies have actually shown that your ability to come to immetropia is seen to only, let's say, between plus 0.5 diopters is only 67% of the eyes where you are actually using a Barrett-Ruque method. Hagues has also demonstrated that it is seen in only 61% of eyes. There has been a very elaborate study which was done, which have compared Hagues-L, Barrett's Truque, and also the Alcon's ORA systems for the intraoperative aberrometry nomograms as well, along with the ASCRS calculator, and their mean achieved immetropic values were seen only in 74 to 76% cases. I was a part of a study at Bascom Palmer Institute, which looked at the unhappy multifocal lens outcomes. And one of the most important reasons for unhappy outcomes for multifocal lenses is residual refractive error. So this residual refractive error, because of the unpredictability of the formula, is a recipe of unhappiness for patients who are post-laser vision correction, especially if they have been done by the first generation of lasers. The second reason for unhappiness post-multifocal and EDOF lenses is, of course, dry eye. We all know that LASIK is going to induce dryness because of the first creation of flap and also ablation on the subepithelial nerve plexus. Of course, this have got reduced with advent of SMILE, but majority of the current generation cataract patients that we are seeing today are all post-LASIK patients. It has also been seen that LASIK is known to also have a slower recovery of dry eye. And in the older age, this dry eye is going to get compounded by the age-associated dryness that we see today, and especially in the Avenue patients who use a lot of computer work. This has also been seen that if you have a patient with dry eye, there is always a challenge also with the unreliable keratometry because of the unreasonable Myers. And this also plays a part to have actually unhappy patients. The third reason for unhappy patients post-LVC is, of course, the older generation lasers, which have already induced higher order aberrations. And on the top of that, it is also seen by a variety of studies that this both spherical and the coma aberrations can actually get induced a lot, and that can give rise to a lot of, let's say, aberrative corneal issues and the optical phenomenons for our patients. This study has actually looked at the diffractive multifocal IOL implantation in myopic post-LASIK patients, and they have actually compared these aberrations in virgin eyes versus the post-LASIK patients, and they have seen that both third and fourth order aberrations were much higher in this multifocal lenses post-myopic LVC patients as compared to the virgin eyes. This is a very nice analysis which had looked at the contrast sensitivity of this multifocal lenses post laser vision correction. And they have seen that the best contrast sensitivity is retained in patients who have virgin eyes. And the worst contrast sensitivity is actually seen post-LASIK patients who have already done with the multifocal lenses. So this is the analysis of the point spread function, which has also shown clearly that compared to the current generation of multifocal lenses or EDOFs, the monofocal lenses will always have much better quality of vision in these patients. So for me, for majority of the patients who now revert back to us, now we have been in refractive surgery for last almost 38 years. And we have been doing LASIK ourselves in our centers since 1994. So whenever we look at our own patients who have come back, who are coming back to us for cataract surgery, my primary basically aim is to offer them monofocal or a monofocal toric IOL. We also do a bit of monovision for these patients. Because monofocal lenses do not induce much higher order aberrations, the maintenance of quality of vision is much better. The patients are already known that they will need some form of small spectacle numbers, which they are already happy about. The way we go on about choosing the lenses is that for patients who have already undergone a myopic LASIK, because there is already an increase in positive spherical aberrations, we select a negative aspheric IOLs such as Technis. And for patients who have undergone a hyperopic LASIK, who have an increase in negative spherical aberrations, we go on to choose A0 aspherical lenses as such. For very small subset of our current patients, we still choose the trifocal or the EDOF lenses, where we see that the laser ablation has been done by more recent generations of corneal lasers. And the zone of ablation is very wide. It is a very well-centered optical zone. And we look at the EKR graph. If the EKR graph depicts that it is a very well-centered ablated cornea, then only we think about the multifocal or the EDOF lenses. But the patients are always told about possibility of requirement of laser enhancement if we don't actually reach the end point of emmetropia because of the unpredictability of the errors as well. Thank you very much to Dr. Chitra ma'am, and over to the next speaker, please. Thank you.
Very valid points, Vardhaman. We look forward to the discussion. And I would largely request Dr. Prema Padmanabhan and Dr. Namrata, and if time allows, a little bit from Dr. Gaurav on this in this session. So be prepared for questions. And we go on to Dr. Vijay Kumar now, who's going to tell us why not trifocals post laser vision connection. On to you, Vijay.
Thank you so much, madam. Thank you for the opportunity. Good evening, everyone. I'm going to talk about why not trifocals post laser vision correction. So since the 90s, the laser vision correction is the most performed procedure all over the world for spectacle independence. Since the 90s, there are over 40 million procedures done all over the world, and it's still now, so far, and it's still counting. And the early beneficiaries are now aging. They've either reached presbyopia or either they developed visually significant cataract. So these are the two subsets of patients who are the early beneficiaries of laser vision correction in the 90s who come to our clinic. The first subset who have not developed cataract, who come to us with presbyopia, will come to us saying, I don't want to wear reading glasses at all. For such patients, we have options like monovision correction by lifting the LASIK flap and doing an examination laser. The second subset who have developed visually significant cataract, they come to us again saying that they don't want to wear glasses post-operatively. So first, for such subset of patients, we would like to do a multifocal IOL implantation. Currently, we have this trifocal IOL design with Toric. So the advantage of placing in trifocal IOL is it provides intermediate visual acuity without sacrificing distance and near vision. And the contrast sensitivity is also shown to be good if the cases are selected properly. So this is a major study done in 2021, which was published in JCRS by Rosario et al., which has shown that the current diffractive trifocal IOLs are compatible with the photoablated cornea with adequate predictability, efficacy, and safety outcomes. So the biggest conundrum in doing a trifocal IOL in a post-LASIK eye is to identify the exact power to implant in the eye to achieve emmetropia. So we would generally take up a aspheric IOL design so that spherical aberration is negated. So traditional IOL power calculation formulas no longer apply in a post-LVC eye. In myopic correction, the anterior corneal surface gets flatter, resulting in lower K readings. And the ratio between the anterior and posterior corneal curvature also gets altered. The asphericity becomes oblate from prolate. So the IOL power generally gets underestimated if we use SRKT or Hofer-Q formula, because the effective lens position, as Dr. Vardhaman has already pointed out, is getting underestimated because of the flattened cornea. But still we can achieve emmetropia with careful case selection and assessment. So what are the important things to assess preoperatively is the most important being ocular surface. As Dr. Vardhaman has already mentioned, LASIK causes some element of dryness, and with aging, it gets accentuated. So it's important to assess the tear film stability using a lippy view, a T-BET or a Schirmer's. And in case if it's unstable, we have to treat it first and make it stable, and then proceed with corneal topography. And once the corneal topography, we get to know the steep axis where to place the incision, and also it will help us to estimate the central corneal power. Newer generation formulas need central corneal power to exactly identify the intraocular lens power. And also with the topography, we can identify whether it's the post-LASIK topography shows regular cornea, especially in the central 4 mm zone, and the topographic results are reproducible and repeatable. And also the centration of flap along with higher order aberrations, especially coma and spherical aberration. And also we will also get to know the angle kappa. Using ray tracing with eye trace, the corneal aberrations can be distinguished between which the aberrations are from the corneal surface or by the cataract. Wavefront aberrometry is also important before surgery to assess the severity of corneal aberrations. The ratio is kept between 0.3 to 0.5 to give accurate measurements. And this is one of the post-LASIK eyes with good centration and with minimal higher order induced higher order aberrations like trefoil and coma. Accurate axial length measurement is very, very important in assessing the IOL power. So the optical biometry using the IOL Master 700 lens star would help, and it should be rechecked using an immersion A scan. A proper dilated fundus examination is essential to rule out any myopic macular and peripheral degenerations before proceeding for the surgery. And an anti-segment OCT to assess the exact corneal thickness, LASIK flap thickness, and stromal bed. In case if we end up in a surprise post-op, we might need to do a bioptics. This would help us for post-operative adjustment. So this is the most important step, IOL power calculation, because the main error is using a normal usual formula can underestimate the IOL power because it assumes that the anterior and posterior corneal curvature is the same. But in a myopic LASIK, the anterior corneal surface is flatter, resulting in a lower dioptric power IOL implantation, which would cause hyperopic shift in such patients who already had a good near vision. The visual acuity worsens for all distances. So these are the important formulas which will help us to assess the intraocular lens power. Haigis L, which will be useful in myopic and hyperopic patients. The Barrett True K, which is equal to or better than the online calculator in myopic LASIK and post PRK. The ASCRS online calculator using Potwin-Hill formula and Barrett-True K, which gets the input from Scheimpflug as well as OCT. And the method to assess the corneal power is Wong-Koch-Maloney method. Angle kappa is again an important thing before proceeding for a trifocal IOL. It's the axis between
1 minute left.
Yes. Shall I proceed?
Yes, yes.
Yes. So angle kappa is the angle between the visual axis and the pupillary axis, between the white and the blue dot. So this is very important because especially in a post-hyperopic LASIK patient, they tend to have a larger angle kappa. When we place a trifocal or a multifocal IOL, there is a chance of post-operative lens decentration, which would increase patient dissatisfaction. So for such patients with slightly larger angle kappa, it would be better if we use a larger central optic zone IOL. So these are my evidences where in a post-LASIK eye, a trifocal IOL implantation has been done, especially in this study by Rosario et al., which was published in JCRS in 2021. 868 eyes have been assessed, wherein 319 were myopic and 549 for hyperopic. The conclusion shows that there is good visual outcomes in high myopia and good precision in hyperopia. The next supportive study is Brenner et al. In presbyopic lens exchange with the trifocal IOL post-corneal LVC. There is utilization of optimized IOL constants in nomogram can improve refractive precisions, which will give a good refractive outcome. So the most important step again is counseling. We have to tell the patient that patient has to be patient for at least 6 to 8 weeks post-op, because the initial 4 to 8 weeks, there is a chance of corneal edema or flap edema, which can cause glares and halos. So we have to wait for 6 to 8 weeks to reduce the inflammation completely, reassess the eye at 6 to 8 weeks, which will give excellent visual acuity if the preoperative assessment is done properly. And there should be the patient should be given extra chair time to focus by lowering their expectations. And this should always tell that there might be a need for secondary procedure in case we end up with a refractive surprise like an IOL exchange or a TCAT. And there are important steps during surgery.
You have to conclude, Vijay.
Yes. Yes, the 3 important steps in intraoperative precautions is to placement of incision. It should avoid a LASIK flap, and it should be outside the flap to minimize damage by the phacotic cannulas or accidental instillation. And in case of post-operative fine-tuning, there shouldn't be no problem in lifting the flap. Thank you so much.
Yes, valid thoughts, Vijay. So let's hear from Samresh before we take on and of course, our expert panel's view.
Yeah, I hope I'm audible, madam.
Yes.
Thanks a lot for inviting me for this talk. And I'm going to be discussing why not the newer generation of enhancing the depth of focus for post-laser vision correction patients. And I just wanted to break the ice by saying that there are many types of lenses. We are not discussing diffractive lenses for my talk, which are also claimed to be EDOF lenses. We're discussing purely lenses which increase the depth of focus. And how they do it is by actually distributing the light intensity, as you can see over here. If I get move the cursor, a monofocal lens also has certain intermediate profile, but a lens that has an enhanced depth of vision will increase your length of focus, just like a shallow depth of focus lens, and give you a larger, more continuous zone of vision, which mimics natural vision. So it stretches and shifts your focus rather than splitting, as would a trifocal lens do, or any diffractive lens do. To address the elephant in the house, we've been using the Barrett-Truquet formula, and I think with that formula, we did do a study which we published, which was to compare the IOL prediction in both the prediction error and the refractive prediction error of 4 commonly used formulas, the Wang-Koch, Maloney, Shamas, and the Barrett-Truquet, which is available for free on the ASCRS and APSCRS as well. We found out that the prediction error was least with the Barrett-Truquet and also with the Shamas formula, and this was statistically significant compared to the other formulas. And we talk of refractive error prediction error also, it was the least with Barrett-Truquet formula. So we were well within 0.5 diopters for most of our patients. So I think at this point in time, with the kind of formulas that we have available, the ever prominent issue of whether we hit target emmetropia or not is less important in today's generation with the better formulas in it. And this is what we concluded, that all formulas performed well, and the highest number of eyes within 0.5 diopters was with the Barrett-Truquet, which fortunately for us is available for free. So with this, I will show you some real life examples rather than some theory, because this is what actually happens in the field. So this is this patient who's about 40 years old, and he's had Contura with me, femto LASIK, Contura vision about 5 years back. He landed up having a COVID infection and developed steroid cataracts in both the eyes, early PSCs, but being a patient with active lifestyle, he had to undergo surgery. Now, this is typically how a LASIK would look if it's done well-centered. This is particularly because it's a topography guided LASIK. You can make out, if you look at it on the right side, that it's a fairly well-centered ablation zone and really well within the pupillary area. And this is the patient's not photopic, not mesopic, but an ambient light pupil, which is where he would be most of the time. And it's a very well-centered ablation profile. And so happened with the left eye. Now, when we plan our cataract surgery, particularly for patients who've undergone any sort of corneal procedure, one needs to keep in mind that what you need to see is the pupillary area or the pupillary axis and the zone of the cornea within the pupil. And the rest of it does not matter as much. But in this case, since it was a wide zone ablation, we safely went ahead and did a surgery and bang on target. This is just a screenshot from my EMR showing literally nothing came out in terms of subjective refraction. Obviously, the AR did show 0.25, 0.5 here and there. And the patient did need a +1 add to jump up from N8 to N6 with a little more ease. And the patient was extremely happy. This is to show you, just as a matter of concept, a preoperative aberrometry showing how classically clear the aberrometry of the cornea would be if the lasers have been done right. And since we're discussing a new generation right now, and this is how typically a cataract would come up as an internal aberration in the eye. And this is just to show you the post-op of the same patient, showing how strikingly these lenses will perform inside the eye in terms of their optical quality, provided the cornea gives them good field to work on. At 2 months, he's okay. There's a 0.5 and his near unaided is N8, needs a 1.5. And with 1.5 with a little more mag is extremely comfortable. And that's a good post-operative patient with an EDOF lens. This was a VVT lens. This is another patient, 55 years old, and has had LASIK 30 years back, probably a microkeratome because she was operated in New York because I think that was a fad then to go and operate over there. And this is how the cornea looks. Again, if you notice, it's still a relatively wide zone ablation, and within the pupillary area, it's a regular astigmatism. And the cornea is well-centered ablations. It was a decently done surgery, and this is not a new surgery. It's been done many, many years ago, almost 3 decades ago. This is the right eye of the patient, and I think similarly the left eye of the patient in the right eye. And this is the aberrometry, again showing that even with an older generation LASIK done, but done in a nice, proper way, the corneal aberration profile is negligible to none. And whatever is happening at the level of the posterior capsule. And this is a very classical patient. So if you do your workup right, you look at the corneal profile, you understand the patient's requirement. I would go, the only reason why I would not offer them a multifocal lens, if at all, is because of glare and halos. That may be pertinent because of an older generation LASIK done, but an EDOF is absolutely no contraindication in such a clear looking cornea. This is where you really test the eyes. So there's a 72-year-old physician who's had an RK. Now, this is not laser vision correction, but just to prove the point out in the end is this is how the cornea looks for an RK patient.
Just 1 minute left.
Yes, please. 1 minute left. All right. So this is how a cornea looks. It's pulled out on 4 sides, but if you can make out the central cornea is still doing well, we use the online formula calculation, and this is where we landed. We did a bilateral VVT toric implantation for this patient, and we landed with a 6.9 unaided and with a 0.5 learning into 6.6. Patient again needs an add of 1 diopters. So not only for new generation LASIKs, but even for older generation, and even to go for so far ahead as to see regular corneas in post-RKs and post-conductive keratoplasties, where we've done these surgeries. This is the same patient showing you the 4 RK cuts that were done some time back. The contrast and the mesopic contrast and the brightness contrast is also well within the normative range, and it's not dropping down with these lenses. And this is documented for all our patients post-operatively. The only thing that you need to tell the patients is they will need glasses for fine print of about 0.5 to 1.25, and there may be a marginal loss in contrast because the light is splitting, because it only is there much light to break up. Again, contraindications are irregular corneas, and that I think is a very simple thing to look into. The staff should be able to pick up irregular corneas and not advise such lenses. Or if you have decentered ablations, is when I will advise a non-aspheric lens monofocal to these patients' eye. The only reason why I would not do a trifocal is because they may land up with dysphotopsia, glare and halos. But I guess with the EDOF lenses, it's very satisfactory. The outcomes are extremely satisfactory, and the patient does appreciate good range of vision, and you get away with the negative dysphotopsias that probably would have happened had the patient used trifocal lenses. But it's always a good idea, just to end this talk, to always document the patient's mesopic pupil, because at the end of the day, what you're treating is the patient's dim lighting condition at best, and not the bright light, because probably everyone will see good in bright light. So good workup can lead to a good outcome. Thank you.
Thanks a lot, Samresh, for summing it up all very beautifully. So we have the expert view of Dr. Ramamurthy now.
I think excellent presentations by all 3 of them, as expected, sharing very similar thoughts to my mind. One of the factors for whenever we talk about presbyopia trifocals is that patient has to be motivated. the very fact that these patients went for a refractive surgery at their younger age group means that they are looking for spectacle independence, and they are prepared to deal with whatever baggage it comes with. And as in all cases, especially in these cases, we always tell them that though we might consider putting in a trifocal or a EDOF lens, there is some expected that it's not refractive accuracy that we'll be able to achieve in every case, but it's more a debulking of the total amount of refractive error that the patient has to deal with. And as Samresh pointed out, they might need a small correction or a small pair of readers at the end of the surgery, though most often they would be independent or spectacles. Now, of course, one of the challenges in all these cases is that, arriving at the correct refractive power that needs to be implanted. If you don't get that power correct, obviously leave on multifocality or the very fact that a residual spherical or toric cylindrical error will obviate the results. So nowadays we have excellent, as was pointed out again by all the speakers, access to excellent formulae. Our go-to formula is the Barrett 2K formula. And along with this, nowadays we have much of a advantage the total keratometry in virgin eyes. When you with this posterior cornea is altered, when using these 2K TK formula, definitely totaling the right formula, the right optical biometry is extremely important. And I would obviously monofocal is often the choice, except in certain areas where the age of the patient at which how many years back the surgery was done was also important, because with some of the earlier lasers, the amount of aberrations that was induced, etc., was much higher. But if it was done in the later part, 2010 and the early 2020s, the quality of aberration itself is much better. And also the amount of refractive error that was treated, if it was a -8, -7, -5 with -4 diopters of cylinder, these obviously the corneas are less suitable for accepting the optics of a multifocal intraocular lens. But if it's a straightforward -3, -2.5 diopters power, which has been corrected or a small hyperopic power, again, you can go ahead and deal with a multifocal intraocular lens. And the happiness of the patient that the patient had subsequent to the basic refractive surgery is also important. The patient was never totally comfortable post laser vision correction, had issues of halos, glare, etc., was never failing that he got optimal results. Such a patient might again not be a good candidate as far as multifocal intraocular lenses. But if the patient had excellent visual outcome after laser vision correction, was happy till the onset of cataract, then maybe these patients could be again considered for a trifocal or EDOF intraocular lenses. Then topography is extremely important, not only for making sure that if there is a cylinder, it's not an irregular astigmatism, but it's a regular bow-tie astigmatism, which can also be dealt with the intraocular lens that we are implanting. But also making sure there's not too much of higher order aberrations in the eye. There's excessive higher order aberration, which could be picked up on an eye trace or even in one of the modern day topographers. Then this might be a relative more than a 0.4 higher order root mean square. Then maybe this would be a relative contraindication as far as multifocal implants is concerned. A lot was being talked about by angle kappa, angle alpha, etc. But today, whether it's for multifocals in virgin eyes or for in post-refractive surgery scenario, I think it's less of importance, and more of us are realizing that we need not really emphasize too much on this. Maybe it's beyond 0.7, 0.8 millimeters, you might stay away. But even up to 0.7 millimeters, we go ahead and implant trifocal implants with reasonably good results. And I think did a right thing by differentiating when we came to EDOF lenses, differentiating with the VVT with the other lenses. VVT, that EDOF lenses also includes other lenses like the Symphony, the AT Lara, etc. And those contain diffractive rings. So they are not much different from the trifocal implants. So when you are talking about optics, which is slightly different from the trifocals, basically VVT might be the way to go. And as was pointed out by Samresh, there is literature evidence to support that these lenses are somewhat more tolerant to a certain amount of aberrations compared to a trifocal implant. So if you want a go-between, when you feel the cornea is not absolutely pristine and ready to receive a trifocal implant, then you could consider EDOF, a true EDOF lens like a VVT implant. Of course, then you have the additional lenses like the monofocal plus, like the Eyehance or the Evolites from SIFI, which essentially play around with a slight bit of central curvature change. These lenses, of course, if the patient is not keen on the dysphotopsia that might come with it, but wants something additional, you could consider these lenses, which their optics are almost similar to a monofocal implant, but they give a little extra as far as the intermediate vision is concerned. Because whenever in doubt, whenever you feel that the patient's expectations are not likely to be met, the cornea is not pristine, there's a significant amount of irregular astigmatism or aberrations, then it might be a good idea to go ahead and implant a monofocal intraocular lens. But having said that, as was also mentioned, we are likely to deal with more and more of these patients as time goes on, and they would also expect spectacle independence. And maybe it has also got to be followed up with a procedure. You might do a laser vision correction even before doing the cataract, so as to deal with the high rod aberrations, the refractive error, get a better corneal stages by doing maybe a topo-guided ablation, and subsequently implant a multifocal implant. Or if there is a residual error, you could do a laser vision correction. And of course, you could also implant a piggyback lens in case it is needed. I heard an interesting concept in this, just to conclude at the ESCRS, where it was mentioned that implant a monofocal implant in the bag and put a piggyback trifocal implant in the sulcus. Wait for about 3 months in case the patient, or with the multifocality, taking out a trifocal intraocular lens from the sulcus, a piggyback lens, is much easier compared to taking out an implant from that. And then you leave the patient behind with monofocus. So I think the kind of choices is limited only by the patient's expectations and by our imagination. And kudos to all three of them for giving a very comprehensive presentation. And I believe that there's much sense in what they said. Thank you.
Thank you, Dr. Ramurthy. Dr. Prema, I wanted to ask you a question here. Are you there, Dr. Prema? Dr. Prema, are you there?
Yeah, I'm here, Chitra.
When you are looking at doing a cataract surgery in a post-laser vision correction, would you look at the refractive error? Do you correct a myope or a hyperope for a premium IOL? You think along those directions also, besides the choice of the IOL?
Yeah, I mean, I would say this, Chitra, I think for any patient who's undergone a refractive surgery, a corneal tomography is a must. Not only to look at, as Samresh said, the centration, but if it is decentered, to rule out a post-LASIK ectasia. Because these eyes would then behave very differently, and all the calculations that you do, imagining that it is a stable refraction may not actually be there if it's a post-LASIK ectasia. So ruling out a post-LASIK ectasia is extremely important. And I will go along with all that has been said by the speakers as well as Ramu. He seldom leaves anything to be added. He's so thorough in the way he sums up things. Yes, I mean, if it is a well ablated cornea, I mean, if it's well-centered ablation, and the patient is willing to accept a small correction cornea, then as Samresh would have done, I would think an EDOF lens is a good option. But if not, if the eye is aberrated and if there are any doubts about the ocular surface, as Dr. Vijay also pointed out, then that needs to be addressed. But if the ablation itself is not has not been well centered or something, then I would just stick to a monofocal lens.
In that viewpoint, I think I would also add that for a myope, even up to moderate myopes, and you could go ahead if the abrasions are not significant to do a premium IOL. but a moderate hyperope. Of course, nowadays, moderate hyperopes also we don't do LASIK, but some of our early hyperopes whom we corrected and are coming for cataract surgery, probably we would think again because of the complex optics which a hyperope causes. So we may not look at a multifocal IOL in those eyes when we talk about.
But an EDOF lens is still is a good option even in those eyes.
Even in those eyes, yes. Yeah, thank you, thanks a lot, Dr. Prema. Dr. Namrata, which would be the formula which you would say is the go-to formula? Are you there, Dr. Namrata? Like, you know, now there is ASRS, there's Barrett's, there's Haigis, which appears logical for you to approach?
So I would say that Barrett 2K is the one which is logical, but then again, I would still, I'll still try to find out what it would be with each of these three formulas.
Yeah, you would like to know whether
what are the other options?
Yeah. Gaurav, are you there? Just one line I wanted. What are your thoughts about the IOL of choice? Like, we know we would look more at a myope than high hyperope. We would not do a high hyperope. We know about the formula that we would like to look at the three ways of doing it. What about the IOL of choice? What would you feel is the safest?
I most often end up using monofocals. I also end up using EDOFs fairly often. Very rarely I have used trifocals and I've got great results, but then all those things which were discussed are very, very important. But that would be a very, very select choice of patients where every criteria is met. So I'll end up mostly using either monofocals, but I don't hesitate to use torics if I have got a good good looking cornea with proper astigmatism. And I wanted to add to the formulas that we are also using ray tracing now. It's inbuilt into the anterior on which we are using. That seems to be giving good results in some patients, but Asker's calculator is what I would use because it includes the OCT based calculation, the pentacam based. So it has actually it goes beyond the three formulas that we are discussing. ASRS also has options of adding other sources. So I would strongly recommend that we use that.
Okay, thank you. Thank you. Dr. Saurabh, would you mind going after the next group? It's okay, you're going to be with us, no?
Yeah, okay.
Thanks, sir, because some of them in the first group have some issues there. So I'm so sorry. And I'm so glad to have you with us all through, because, you know, you had to travel very fast to join in, to be with us. And thank you so much, Dr. Saurabh, for adjusting. So we go on to the first set of talks, which is irregular astigmatism, post-keratoplasty and keratoconus. And discussing these our speaker is Dr. Charuta Puranik, who's a senior consultant ophthalmologist, is a cataract and a refractive specialist from KIMS Hospital, Secunderabad, and her talk is going to be monofocal IOL is the way to go. Now, contradicting her is going to be Dr. Shreya Ramurthy, who's a consultant cataract, cornea, and refractive services at the Eye Foundation group of hospitals. And he is going to say that toric IOL is the answer in more often than not in keratoconic or eye or in post-keratoplasty. And giving her expert viewpoint on this is, again, we will be calling Dr. Prema Padmanabhan. And so on to you, Dr. Charuta, let's hear from you about why you feel monofocal is the way to go.
Good evening, everyone. So thank you for the opportunity, Dr. Chitra, and it's a very interesting and challenging topic. So I'm going to delve right away into the topic. So I'm going to start off with a case. This is a 24-year-old female patient who presented to us with the left eye like this post-DALK, 6 years post-DALK done for keratoconus in some other hospital. She had also suffered from microbial keratitis. As you can see, there is a scar over here. And this is her refraction in the left eye, -10 sphere, -3 cylinder at 25 degrees axis. With this power, she was correcting to 612, but obviously, if you can see, there is an isometropia in both eyes. So we went ahead, we did, she also had a steroid-induced cataract in the eye. And we went ahead and did the IOL master, which is showing a difference in the keratometry values, which from the topography scan. And we also did the specular to complete the evaluation preoperatively. Based on this value and based on the keratometry values that we had during refraction, we decided that the spherical equivalent power was somewhere between 2 and 10 because of the axial length, considering standard K and also the K that we took from the IOL master. So therefore, a spherical equivalent power of plus 7.5 was taken in between, and we had obviously counseled the patient that she would have a refractive surprise. I planned a sclerocorneal tunnel incision in order to create a surgeon-induced astigmatism of 1.5, and then at the end, this is her last follow-up. You can see there is a piggyback IOL of the Toric IOL along with a sphere of +2. So totally altogether post-op day 1 she was 6'9", and now 1 month post-op she is 6'6" parts. So this is I'll come back to this case later on. This is to say that the grapes are not sour. Now I'll come to the other half, that irregular astigmatism in keratoconus. What are the facts that we know? And Dr. Chitra has asked me to keep it to very theoretical and evidence-based talk. So here goes the review of literature that we have. Now we know that IOL power results of cataract surgery in keratoconus have long been suboptimal, and with significantly fewer patients achieving within 1 diopter of the intended refractive target, even with a monofocal lens. And a hyperopic shift following the surgery is also commonly described, particularly in patients with more severe stage of the disease. And we have a myriad of challenges which we face while selecting a suitable lens. That is, standard formula, IOL calculation formulas predict effective lens position based on the parameters of a normal eye, whereas that cannot happen in these cases because of the abnormal relationship between the anterior and posterior corneal curvature, the varied anterior chamber depth and axial length, and also standard keratometric indices depend on the predictable ratio between anterior and posterior corneal surface, which is progressively being disrupted in keratoconus. Next is the question of which K. So simulated K value is actually derived by taking radius of anterior corneal curvature and a standard keratometry index of 1.3375. It assumes a fixed ratio. In keratoconus, this ratio is altered as said before. Now, Kamia et al. Calculated the total corneal refractive power, TCRP, using ray tracing methods. And this considers both anterior and posterior corneal surfaces in keratoconus, and he compared it with SIM-K value. As you see in the graph, the degree of variation between SIM-K and the TCRP values in keratoconus eyes is markedly high as compared to those in normal eyes. And this difference becomes more evident as the disease progresses. So likely the cause of hyperopic refractive error post-cataract surgery in keratoconus patients is due to the overestimation of this TCRP. Another to add to that is the decentered cone, which doesn't coincide with the visual axis. Now, what else? So rotational stability is actually a major endpoint analysis of the Toric IOL. And it greatly depends on capsular bag size and axial length and associated myopia. So theoretically, all patients with keratoconus who have axial myopia or should be actually prone to IOL rotation, although there is no case report which is actually reported this. Now, residual astigmatism can be produced due to rotation of the Toric IOL post-surgery. Again, let's look at the pooled studies which we have. So this is data from 2020, and Kane et al. have studied 147 eyes of 147 patients for all stages of keratoconus, and the keratoconus Kane formula actually did very well in all stages. And to avoid hyperopic result, which was mentioned before, they suggested some corrections also. That is, in mild to moderate keratoconus, there should be no correction in the Kane keratoconus formula. In the moderate, you can target myopia of 0.75 to 1.5, and for a severe cases, -2 to -3 should be aimed. Now, this is the only study which has actually compared normal IOL formulas with IOL formulas that are specially designed for keratoconus patients. And with all this in mind, we are only talking about monofocals here. Now, we have some latest data from 2023 again, wherein Ling et al. Have upped this number and compared 160 patients. the accuracy and outcomes of different intraocular lens power calculation formulas in keratoconus for with monofocal IOLs and with toric IOLs. So in these 160 patients, 136 received the non-toric lenses and 24 received the toric lenses. That is, the lesser number itself says their preference. However, if we look more carefully at the data also, the patients who underwent topographic, the patients who underwent the surgery, in both the groups, the mean refractive error, predicted refractive surprise was not different between the two groups. That is the first and foremost pointer. Next, if we go to see the subgroup analysis, in all the subgroups also, there was not much difference between the average post-operative spherical equivalent and the final CDVM. More notably, if you can see, 7 of the patients were who received a monofocal IOL stopped using the RGP after the surgery, whereas all 3 patients who got the toric lenses continued their RGPs even after surgery. Another interesting, I was searching for some interesting data, that is in keratoconus, what is the contrast sensitivity or higher order aberrations. And this is a group, Sneer et al., who have assessed correlation between wavefront aberrometry and contrast sensitivity in patients with keratoconus. And they have also sub-analyzed patients with keratoconus having 0 logmark. So there were significant differences between groups between higher order aberrations for trefoil, total coma, trefoil, and spherical aberration. The contrast sensitivity is again significantly lower in keratoconus compared to control groups, and significantly lower in keratoconus with a visual acuity of 0 compared to the control groups, which means that even if you have a 6/6 vision acuity, your contrast and your higher contrast is going to be lower than somebody with a normal, and your higher order aberrations are probably going to be higher than somebody with a normal eye. So why is this important is, this is another case series wherein the changes in astigmatism and corneal higher order aberrations after phaco with toric IOL implantation for mild keratoconus was checked, and they showed that the corneal higher order aberrations were changed from 0.47 to 0.52 post-operative, which is not statistically significant, but however, it was a slight increase in the HOA. Now, if we again see that what happens if you make a mistake, if there is a slight rotation or if there is a slight error in calculation, what happens? Residual astigmatism, which is greater than expected, then aberrations tend to be higher. So this patient is obviously going to be intolerant to higher order aberrations already from beginning, and you are also subjecting him to a probable increase in the HOA. Again, contrast sensitivity, this is a repeat thing. Now, what else do we not know? What is the comparative value of such measures, that is contrast and HOA, toric versus monofocal in keratoconus? We don't know what is the level of spectacle independence comparative value between these two. I didn't find any literature about quality of life and any literature about secondary interventions that these patients underwent, which would be something that I would want to know. Coming back to the case 1, and this is what the questions that were asked to me, and which I obviously didn't have an answer from the relatives of the first patient. Will the graft reject? What will happen if the graft rejects? What will happen if there is another infection? And this is post keratoplasty patients. Obviously, even though I put a piggyback lens, the patient is now 6/6, and another keratoplasty was definitely not justified in these patients. But these are the variabilities that the patient will face in future. So to conclude, there is no change in the corrected distance visual acuity between toric and non-toric. There is a lesser margin of error allowed in the toric IOLs for keratoplasty. Post-keratoplasty fate of the graft is a challenging situation, and further studies are required for real-world scenarios as to how the patients feel after a toric versus after a monofocal lens. Thank you for your patient listening.
You're on mute.
Dr. Chauta, that was a very crisp talk, very informative. Before Shreyash takes his talk, I just want to tell that after the expert viewpoint by Dr. Prema, I would like to take a question with Dr. Namrata and Dr. Minu Matan. So on to you, Shreyash.
So good evening, everyone. I hope my slide is visible. So what I would try to do over the next few minutes, Dr. Charuta extensively covered some of the literature. While my aim would be to not just say that toric IOL can be used in every keratoconic and every post-graft patient, but it is to merely try and highlight where we can use them and what are the factors that we need to keep in mind if we are using a toric IOL in these conditions. Now, we all know a toric IOL is preferably only for orthogonal astigmatism. And what we mean by that is a regular astigmatism in both magnitude as well as direction. That is repeatable measurements even in terms of axis. Now, this is where in patients with keratoconus, it becomes a little bit more challenging. But before broadly saying keratoconus, we also need to delve a little deeper whether the patient has a central cone or a decentered cone, because you are more likely to get a repeatable K reading both in terms of direction and magnitude in a more centered cone than a decentered cone. Was the patient a previous RGP or Roske user, and are they willing to continue wearing contact lenses after cataract surgery? If that is the case, then the debate ends here, because then monofocal is the answer, because any irregular astigmatism is going to be taken care of by the contact lens itself. But very often in our cataract surgery patients, the diagnosis of keratoconus can also be incidental. That is, they've had a stable keratoconus right from the age of 20. Now they have presented for cataract surgery at 65 or 70. They are not really been bothered extensively by their keratoconus itself, and they've been wearing glasses till a particular age. So these are patients where the cornea can be further optimized and can undergo a cataract surgery. So this is just one such example. These are some of the points which Dr. Charuta had already covered, where she mentioned that poor repeatability and accuracy can be a concern. The ratio between the anterior and posterior cornea is not fixed. And these are things, and where do you measure, whether you're exactly measuring at the vertex or whether you're measuring the steepest point. All these are the primary reasons why you get variability in measurements. But having said that, if you can optimize the cornea, improve the repeatability of the K reading, it is worthwhile doing so in these patients before taking them up for cataract surgery. This is just another example of a patient who presented for cataract surgery, but incidentally had keratoconus on examination. We first subjected this patient to a topo-guided PRK, and once this cornea regularized and we had a repeatable K reading, we could very safely take them up for a toric IOL implantation. A little more advanced cone, this patient was not interested in wearing contact lenses, had not been wearing contact lenses, had a poor UCVA even before the onset of cataract surgery. Now, this was an opportunity to optimize the surface before going ahead with the cataract surgery. Intracorneal ring segment was done, the amount of astigmatism reduced, the apex flattened. Subsequently, we got a more repeatable K reading, both in terms of magnitude and direction, and then went ahead with the cataract surgery. The video itself is not much, it's just to merely highlight in case a laser cataract is being used post intracorneal ring segments, the edges can cause a diffractive effect, and therefore it's important that you gather the rexes and ensure that it is there are no tags before you go ahead with the cataract surgery. The rest of the surgery is pretty straightforward. So in case the patient is willing to continue contact lenses, like I said, please continue, because if you put in a toric IOL, when you put a contact lens on top of a toric IOL, you'll end up uncovering the astigmatism, and the patient will require glasses on top of the contact lenses to correct whatever cylinder has been induced by the toric IOL. But most of our cataract surgery age group patients are less likely to wear contact lenses in the postoperative period, especially if it's being prescribed to them for the first time. So in these cases, a toric IOL with aiming for a slightly myopic outcome is important, but an adequate counseling is necessary. Again, outcomes are very, very variable. You look at various studies which have looked at it based on the stage of keratoconus, whether any preoperative procedure has been done. Each stage, early stage, you could do a topo-guided PRK. A moderate stage, you could combine it with the intracorneal ring segment. A very advanced stage of keratoconus, you could do a staged procedure, first do a DALK, regularize, and then subsequently go ahead. But each of these patients can be addressed appropriately. PMD is a situation where you have less irregularity in the central cornea, and therefore the K readings are much more repeatable. However, you may have higher degrees of astigmatism and you may require customized toric IOLs. In post-PK and DALK, it's important that we wait till we complete suture removal. It is not necessary that every single suture has to be removed. There might be situations where you've reached an acceptable level of astigmatism. And let's say for this example, this patient for the last 1 year had a stable astigmatism, had 4 to 5 sutures already left in situ, but these sutures were not becoming loose, were not going to disintegrate in the time period, but had developed a steroid-induced cataract. So in these patients, it's better if you remove some of those sutures which are in the opposite axis, you might actually end up increasing the amount of astigmatism. And therefore, it is just better to leave them aside and go ahead with the cataract surgery itself. This is another scenario where a patient post-DALK had also developed a steroid-induced cataract. And as we know, in DALK, the chance of rejection is very less. The long-term survival is very, very good. And these are patients where even higher degrees of astigmatism can be corrected very, very comfortably. So this was a DALK for post-keratoconic patient and had a significant residual astigmatism, almost 9 diopters of astigmatism. And if you implanted a monofocal IOL, even wearing glasses for such a high cylinder would almost be impossible. So the aim here is to really debulk the amount of astigmatism. We are not aiming at emmetropia. This is a customized toric IOL and from the Care Group lens. And this Ultima Smart Toric can correct almost any amount of astigmatism that you require. So by debulking the amount of astigmatism, we are now able to reach a stage that the patient has a very, very acceptable residual error, which they can now wear comfortably with their glasses. So to conclude, toric IOL is a definite possibility, even if the patient has irregular astigmatism. It's important that you meticulously select the case, do a careful planning, optimize the surface before you take them immediately up for a cataract surgery. And again, counseling the patient, explaining to them the purpose of doing a toric IOL in these patients is really to debulk the cylinder, provide a better uncorrected and best corrected visual acuity, whereas we are not aiming for within plus minus 0.5 diopter like we do for our regular set of cataract surgery patients. Thank you so much for your kind attention.
Thanks, Suresh. That was again another wonderful talk. So let's look forward to what Dr. Prema has to give her expert viewpoint.
Thanks, Chitra. It was a pleasure listening to both Charuta and Shreyas. I would call this actually a debate because the two views were not really, contradictory to each other. I think both of them have actually positioned the two choices that were discussed, the toric IOL and the monofocal IOL. They have positioned them appropriately because there is a place for each. As Shreyas rightly said, if it's in a keratoconus, if it is a central cone, or if you can bring the astigmatism to closer to a more regular astigmatism, then there is just no, you're actually, the patient would benefit from a toric IOL. Penetrating keratoplasty and keratoconus are two situations which have something in common, but they are slightly different in another respect. What they have in common is that they both represent situations where the challenge lies in the corneal optics. And you're using the cataract as an opportunity to correct the corneal optical errors. But when you look at irregular astigmatism, we have to understand that it consists of lower order astigmatism, it consists of higher order astigmatism, some amount of coma that presents as astigmatism, some amount of spherical aberration that presents as a defocus. And so there is an interplay and quite a dispersion of various aberrations that interact with each other and result in the visual disability. So to find out how much of that astigmatism is really a refractive, regular astigmatism and how much can be corrected with a lens and how much will remain uncorrected is important. And as Shreya rightly pointed out, counseling these patients is extremely important. For them to understand it's not like other cataract surgeries, for them to understand what they can expect and more importantly, what they cannot expect after surgery is an important part of it. These patients would probably go to any cataract surgeon, but it is best to refer them to a place where the corneal diagnostics are available. Simply because these patients require a more detailed corneal examination. For a grafted patient, I would look very closely at the graft, and as Charita pointed out, doing not just a specular microscopy, but to examine, but to know the primary pathology for which the graft was done, for you to be able to predict whether this patient is likely to require another graft in the future. Because if he does, then this entire exercise is futile. These are eyes with already complicated optics, and now you're introducing yet another optical element in the form of an intraocular lens. So while it has the potential of correcting some of those errors, it also you also run the risk of complicating the optics still further. So one should be careful about this. Some amount of, as I said, interplay between aberrations, like some amount of coma with some amount of astigmatism actually improves vision. But this is more easily demonstrated in an optical bench than in an actual patient. So I think I would say that the way Shreyas has made an algorithmic decision tree about when he would use a toric lens and when he would still opt for a monofocal lens is an important thing. And let's not forget that at the end of the day, contact lenses are always there for post-PK eyes or post-keratoconus eyes to improve the quality of vision. And that's all I have to say.
Yeah, thank you very much. Beautifully summed up, Dr. Prema. I see that Dr. Namrata Sharma is not there. So I think I would, Dr. Nikhil or Dr. Praveen, I would take a question from you. Oh, Namrata is there. Good. Dr. Namrata, now can you tell us, there's a complexity in getting the K value. So do you have a particular go-to instrument to measure the K in a keratoconus patient, or would you like to check it on different devices? How would you do it? Are you there, Namrata? I think she's not connected somehow. I would, since there are other cornea guys here, I thought I could take the thought of Dr. Nikhil or Dr. Praveen, if you all are there. Both of, yes, Dr.
I'm here.
Yeah.
Hi, Chitra, and very nicely summarized by Dr. Prema. But I actually had a question for either of you, Charita or Shreyas. At what stage, not a cataract surgery, but doing a transplant and then doing a cataract surgery after the transplant? I mean, what kind of case on the scan or on topography will prompt you to do that, to take that approach?
Do the transplant first and then the cataract surgery, you're saying, sir?
Yes.
So predominantly, I would, restrict it to either a dystrophy where the cornea has to be corrected, or advanced keratoconus where the patient is not willing to wear scleral contact lenses in the post-operative period. Probably these are two situations where I would do a graft first, wait for the K reading to stabilize. Of course, all this is keeping in mind that the cataract is not too advanced or you don't have a mature cataract already. But then if it's a relatively early cataract, then the cataract can definitely wait and we can probably do a DALK in these advanced keratoconus, wait for the BCVA to improve, the overall surface to improve, and then consider a cataract surgery. Maybe a year or so after the graft.
Yeah. So as far as the K value measurement, which I'm coming back to again, I know it is a huge challenge in a keratoconus. So if the K is, the cornea is fairly regular within 3 millimeter zone, or would you look at the EKR value, or would you rely on the IOL master? I'm not talking of advanced keratoconus, mild to moderate keratoconus. Which would you look at? The EKR maps, will you trust the IOL master for the K? The Pentacam? Shreyas, Charuta, Dr. Meenu Mathan?
Any two which are similar to each other. That's what I followed for the first case also, or generally. So
I think it's important to have measurements from 2 or 3 devices, and more importantly, to the extent possible, have repeatable measurements. And of course, the integrated K calculator also can be used, where you have slightly varying values from 3 different devices. Then it gives a certain weightage to each of these values and gives you the best possible result. Again, these are obviously, like was already mentioned by Prema Madam as well, we are not aiming at absolute refractive accuracy. There is a significant possibility of having some residual error. What could be the best option and how much we can debulk the refractive error is probably what we are discussing.
And just one last question, Dr. Meenu, the formulas which you're looking at, I know we are cataract surgeons and this is so typically a cornea topic. There is this SRKT, which seems to be also popular, surprisingly. And there is this Keynes formula, there's Barrett's formula. Both Namrata and Meenu, just one line answer. Which would be your choice of IOL formula in a keratoconus patient? I had a question for you, Namrata, but it got answered.
Yeah, I got disconnected. I would use Keynes formula. I think for keratoconus, the Keynes formula is the one which works best. But having said this, we will, like I said, we will use other formulas also. But as per all the studies also and in practical experience also, I think Keynes is the one which works best for keratoconus.
But why is it that in Keynes formula, I did come across that you take the anterior corneal measurements, but do not consider the posterior corneal measurements values? Is it that we would end up overcorrecting?
Yeah, because the posterior cornea is going to be much steeper than what it is when you generally would, calculate the power. And even if you look at keratoconus, the only thing is that, I mean, first, this thing that would come, the changes that would happen would be posteriorly. So that would be far more steeper as compared to the anterior part. So that is why
better to take the anterior
part is taken, because otherwise that will fallaciously give you a false K reading.
Yeah. Dr. Meenu?
I don't have comparisons of my own experience. I use only Barrett's right now, but I have to see Keynes also and see whether they're coming different, much different our scenario. But Barrett's is okay working for me for this also.
But I do agree with Shreyas that doing a topo-guided surface regularization also makes sense in these early keratoconus patients. Yes, Dr. Ramurthy and Dr. Saurabh, we'll be taking your keynote address now. Next. Sorry for the delay. Yes, Dr. Ramurthy.
Just wanted to add a quick word. If we are considering toric lenses, maybe the Barrett 2K toric formula would be the way to go. Of course, getting the right K readings would be a challenge, as already discussed. Very recently, Barrett has come up with a Barrett keratoconus formula, where specifically addressing the keratoconic eyes. I've heard about it. I've briefly read about it, yet to experience it. Maybe once it gets validated, then maybe that would be the formula you could consider in these eyes.
Thank you. That was well discussed, and we would now go on to Dr. Saurabh Patwardhan, and who was really waited far too long. And thank you so much, Dr. Saurabh. And he definitely needs no introduction, and he heads the Nandeep Eye Hospital and has had so many fellows and so many students coming out, and the kind of YouTube presentations which he has. I think any of us at any age are still learning from him. So kudos to you, Dr. Saurabh, and let's hear your very interesting talk on the challenges in a routine cataract surgery. And following this, since there has been so much of a change of sequences, following this, it will be the unilateral cataract debate, which will be taken up, and then finally the Fuchs with early cataract. So yes, on to you,
Yes.
Doctor.
Thank you very much, Dr. Chitra Madam, for this kind invitation, and it's an honor to give this keynote address. And so far, we have been, I think, seeing all the complexities of complex cases, and my topic will be complexities in a routine cataract surgery. So it is going to be little interesting. So when this topic was given to me, I was just thinking what exactly is mean by a routine cataract surgery. Now, we know what a routine is. A routine is a fixed or a regular way of doing things which is followed consistently over a time. Now, when we say it's a routine or regular cataract surgery, what we mean is that we are expecting very predictable steps and predictable results at the end of it. But sometimes I think the most complicated, because we are doing a lot of routine cases as compared to complex cases, I think overall there will be more complexities associated in terms of numbers with routine cataract surgery than the complex surgeries itself. So just a clip to start. You know, all of us do this treadmill routinely, but sometimes the routine things becomes little complex when you approach things little differently. So the same routine surgery for us may become little complex if we approach things, little differently. So we'll start with the first experience. So this was a routine surgical, cases, because I always divide my surgical list into a routine cataract list and a complex one, so that I can give adequate time for complex surgeries. So this was part of routine case list, and I was doing, and I heard a commotion outside in the preparation room where we had a patient who was having a kind of a panic attack. The reason was that patient had intense claustrophobia. So patient was suffering from claustrophobia, and that's the reason why he had delayed the surgery for so long, because he knew that the drapes will be put on his head and will be claustrophobic, and already he was with that anticipation, he was having panic attack. So I spoke with the patient. I told him, because these are the cases, maybe I have to take him under general anesthesia or sedation, or, to relieve his anxiety. But this was a routine cataract surgery. So I just spoke with the patient. I told him that we'll put the drapes, but your other eye will be always open. My assistant will be holding that drape, up. And whenever you feel like, looking around, you just tell me, I will stop the surgery, and you can look through the, so once we lift the drape all around, you can just look around and see the assistant, you can speak with them, and then we can go ahead. And this simple step relieved a lot of his panic, and he calmed down, and he was extremely happy at the end of the surgery. So sometimes these kind of incidences happen even with routine cataract case, and we may have to approach them differently. Now, though it is a routine cataract surgery, sometimes we miss important histories. So just showing one more, case here. Actually, the audio, I'm not sure whether it will be there or not. I was just starting the case, and the patient started talking with me, saying that this is my second eye surgery, so please do take care. Now, when my assistant showed me the case sheet, there was no history of any previous surgery. So I asked her, it was like 35 to, I think, 37-year-old lady. And she told that she had LASIK refractive surgery done few years back, and she has not, told this to her in-laws, and that's why even in pre-operative examination, she had hidden that. The keratometry was 3940, so probably that's why we missed it, and we don't do topography as a routine for all our patients. Now, already I had planned EDOF for this patient. Luckily, in this case, I had a library. So once she told me on table that she had undergone LASIK, so now I asked my fellow to do the calculation with online calculator and Barrett-Ruque formula and find out what is the IL power. And luckily, as I said, I had already the library of these lenses. Otherwise, I was stuck in this case. So luckily, everything went ahead smoothly. But I think missing important history, because many times we may not ask, or sometimes our assistants or optometrists miss taking a proper history during their examination. So that may lead to certain issues during routine cataract surgery. Now, sometimes we miss steps. I'm just going to show you another surgical case where the patient demanded surgery under block. So generally, I do all my surgeries under topical anesthesia, but this patient specially demanded when he came to the preparation room that he wanted block. So my fellow gave the block, and after that, the patient was immediately shifted to OT. So you can see that as I started my capsulorhexis, immediately once I opened the main incision, there was gush of viscoelastic outside, and that was because still the intraorbital pressure was quite high. So normally we don't expect this kind of sudden upthrust when you are doing CCC, but because it was a peribulbar anesthesia which was just recently given, there was no time was given for it to dissipate, no ocular massage was performed, and straight away, because my earlier surgery was already over, patient was taken on table and draped, and this increased intraorbital pressure led to this kind of upthrust. So all throughout the surgery, there was considerable upthrust. I managed it later by using the small side port incision for doing the capsulorhexis, and all throughout I was little careful. I gave more time for the case to complete. But I think if we miss the steps, so the important message here I realize is that if the fellow or student has given block, they should know that you have to give some ocular massage and wait for a certain time before the patient is shifted for the surgery. Sometimes when you are going ahead now, this is another case which I would like to show. I was preparing to take the incision with the side port blade here, and I was about to stabilize the globe, and the moment I wanted to stabilize the globe, the patient just in split second moved the eye away, and that led to, you can see the blade is inside the cornea and just moved and created a very large incision there. So it was much larger than what I had wanted, obviously. And once we have this kind of situation, and this was just a routine cataract surgery, but because of this large incision, now I have to be extra careful all throughout the surgery. Now here we have to think of options, what can be done. So difficulties will be, there will be leak expected, and the regular parameters will be risky. So one option can be just suture the incision, make a new small incision, go ahead, or we can do single-handed phaco so that there is less leak around, and you can reduce the vacuum and flow rate. So I went ahead with single-handed phaco. So I tried to use just main incision for most part of the surgery, and only in places where I needed the second incision, I used it. And whenever I was using second incision, you can see that there was quite significant leak there from the side incision. It was quite big side port incision, but by changing the parameters, reducing the phaco parameters, I could manage it in this particular case. But this was a regular case which turned out to be complex just because of that split second patient's eye movement where I had not stabilized the eye. Sometimes we do things a little excessively, trying to make it safer, but land up with more problems. So this is one of the video from one of my colleague, and he's using the side incision for putting the OVD, and he injected excessive OVD. This was a heavy OVD, so difficult to wash out as well. And with this kind of excess OVD, you can see even the cornea becomes hazy as well as the iris prolapse. So you have to be very careful. Simple excess OVD makes things little difficult and making it more complex. Another case I wanted to just show here, routine case, and one of my colleague decided to inject OVD, but he injected excess of OVD. So otherwise the capsulorhexis was going fine, though it was little bit on larger side. But the moment he started injecting the OVD and he excessively injected it, it caused deepening of the anterior chamber further. The zonules probably got stretched because of and probably the sclera was not that rigid, maybe a younger patient or a myope. And that led to just tearing of this capsular axis away into the zonules. So just because he tried to, make it extremely safe by deepening the chamber, it in fact caused more problems. Now, another case where small capsular axis is done, first hydrodissection, and then in second hydrodissection, there was excess buildup of pressure in the posterior part. You can see that, and it just caused hydrorupture. You can see that in slow motion that the posterior capsule just ruptured, and this was a very typical pupillary snap sign which was seen. So otherwise, this was just a posterior subcapsular cataract, but hydrorupture resulted in impending nucleus drop, which had to be managed. So a pupillary snap sign in otherwise a regular or routine cataract surgery led to a complex situation, which then had to be dealt with. Okay. This was another case from one of my colleagues, completed the case, and IOL was already implanted. It was just viscoelastic has to be removed, and see what was done. So while trying to go behind the IOL, the entire bag was pulled and caused iatrogenic dialysis. So this was just about to finish the case and caused iatrogenic dialysis. Though the IOL was stable in the bag, obviously with larger dialysis, there is always a chance that once the capsule starts fibrosing, the IOL may get decentered. So colleague decided that I will put a CTR to stabilize the bag. I just wanted to show what things went wrong while putting the CTR. So the first eyelet is already inside the bag. Now you have to press this CTR down so that it doesn't, jump into the sulcus. But that's exactly what is happening here. These CTRs are very springy, so you have to guide them into the bag properly when you are using, you're doing a manual injection of the CTR. Now using another grasper to push in the CTR, but the second hand, the Sinski, should have pulled the CTR inside and pushed it into the bag, but it was not guiding the CTR, and which means that now the CTR is going into the sulcus. You can see that at this point, the surgeon should have stopped, but continued and thought that might be able to put it in the bag, but ultimately lost control over the eyelet as well, and that CTR went to the angle. Surgeon tried to retrieve it, but now went into a little bit of panic mode because already there was one iatrogenic complication. So, and this happened. So he called me, and I corrected it. So first thing was to get hold of this eyelet, which had gone into the angle. And with the forceps, I could, find out the eyelet here. And then I pulled out the CTR. You have to be very gradual in pulling this CTR out so that you don't damage the bag further. And now I will guide the CTR again back into the bag by using proper technique of CTR insertion. The anterior chamber was again inflated. And now the second hand Sinski has to be properly used to dilate inside the bag. So once first eyelet goes in, the second Sinski should be pulling it, and it's better to use slightly longer Sinski so that it doesn't slip when you are putting the second eyelet inside. Now you can see how I am guiding the CTR right into the bag, and the position is now correct. It is guiding the CTR into the bag, avoiding it to jump out into the sulcus. And at the end, I'm using the grasping forceps to push it in, and then use the Sinski hook to hold the eyelet and then put it in the bag wherever it is needed. So it's important that to avoid iatrogenic complication, obviously the surgeon should have been more careful while going under the IOL. But if you have it, I think you should be able to manage it also well. Sometimes it happens that the surgery is about to end. You have done a good job and just about to visco wash. So another colleague of mine doing the surgery, there was a small desmet, probably detachment near the incision, which happens very commonly. But here the surgeon withdrew the probe, IA probe, and what happened is that the irrigation started pushing these desmets away, and at the same time, the IA probe held that desmet and caused a big tear. So you can see that. Now the surgeon tried to reflux push the reflex button and release that descemet membrane from the eye probe, but it was not happening. Probably the capsule had not completely occluded the tip. So he had to slowly manually release this descemet. And of course, we have to manage this by putting air inside. And but this was something which was completely unnecessary, just because at the end of the surgery, the surgeon was a little bit not mindful of what was happening at the incision site, and that again converted a routine regular cataract surgery into complex one. Luckily, the tear could be managed just with air injection, and patient did quite fine there. You can see the big tear there. So you have to be mindful, even if it is a routine cataract surgery, you might be doing lots of surgery in a day, but you have to be mindful for each and every step. Now, this is a case where the surgery has been completed. The pupil has come down a little bit during the procedure. It's a plate haptic trifocal IOL, which I have to push inside the bag. I thought that I have pushed the IOL in the bag and started with viscoelastic removal, OVD there. And when I removed OVD, I realized that the IOL was not centered properly. It was decentered. Now at this point, always you have to investigate why it is decentered. You should not just close the case at this point. So you have to think why this is not centered, whether it is in the bag or not, if the bag is not stable, or if the PC is not intact. You have to take care of that on table. Don't think that it will correct itself. So when I examined, I realized that the trailing haptics were not inserted into the bag while injecting properly. So that's the reason why the IOL was decentered. Now, if I just close the case and, the patient post-operatively is not going to be happy with the decentered IOL, and I have to take the patient back into the operating room and correct it. So it's always important, before you close the case, make sure that IOL is in the bag and there is no decentration of the IOL on table. Otherwise, you have to find out the reason and make sure that it's corrected then and there. Okay, Dr. Chitra madam, do I have more time or should I finish here? I can't see. Hello?
1 minute left, sir.
Hello?
No, doctor, if you are ready to conclude, then it's fine too, because we are running late, not because of you, but because of discussions.
Okay.
And I want a question or two to be asked to you.
Okay, fine. Then last video I will just skip. So that's the end of my presentation. Thank you.
Truly wonderful set of videos it was. And Dr. Meenu, Dr. Gaurav, do you have a question to ask this very eminent surgeon?
He's already given all the answers. He's beautifully demonstrated all the mistakes that can be done and then how to tackle them. So I think very nicely managed, and he's shown a gamut of common complications that we can have. So I could relate to them because these are things that you can commonly do. Only thing was that the last one, the one that we just saw with the descemet, that was quite unique, and it was scary as well. So I was just wondering in my mind, I was thinking what we could have done if reflux was not working, because it's a very tricky situation, and there's little that you can do. It's almost like an IOL which is stuck in the cartridge, and you want to neither can you go forward nor can you come out. And so any thoughts? I mean, I don't have a clear answer. I mean, you did manage it quite well.
So what we did, like this happened to one of my fellows actually when he was operating, and he was stuck there, sitting with the descemet in the eye probe and asking what should I do. So we pushed the reflex button, but as I said, probably the descemet was not completely occluding the eye tip. So that's why even if reflux was happening, it was not getting released. We tried even the pinching the tube also, but ultimately what he did was with the left hand Sinski, because at this point we cannot take over, he has to manage it himself. So he could release that descemet, and luckily it was intact. So that was fine for us.
So my thought was that if we just kind of disconnected the aspiration from the back end of the thing, somebody who was assisting, that would probably, I mean, I'm not sure, because the infusion
actually it was, I think, more because of the maybe capillary action that it had gone, and because it's very thin, So it's like, got stuck there. So
But anyway, it
luckily
was well
nothing
managed,
happened.
so we got
Yeah.
away with it. But it looked very scary, and it's a good lesson that one has
Yeah.
to be careful. Another thing which I wanted to add here was that sometimes, if you're pushing, it happened to one of my consultants who was operating and, in a glaucoma surgery from a side port, she pushed towards the, end of surgery. She was pushing from the side port viscoelastic to form the chamber, and it caused a big DMD.
Yeah. Yeah.
It went across and a whole inferior, temporal to inferior DMD. And then there was viscoelastic under the DM. It was crazy how to handle it. We did like 3 attempts at kind of doing it. So, I mean, sometimes you have to be very careful when pushing any fluid or viscoelastic from side ports, that we end up trying to push it like almost like hydrating the wound. But one has to be very careful that you don't end up creating a DMD at that time as well.
Actually,
Yeah. So I had one.
Tear in the DM. I actually wondered how an air bubble alone sufficed. Maybe you could have needed a more long-acting like a C3FA.
Because it was a superior, basically the fellow was doing a superior incision, so the air luckily was enough for this patient.
Yes, Dr. Meenu.
Okay. Yeah, Saurabh, as usual, these are all things which happen to all of us, and you have rightly shown them how to manage and all those. So, what about when you do cortex aspiration? I do. These are things which are happening to me also. So, when you do cortex aspiration, and especially when this 7mm, 6mm pupils come down a little bit, and we have a tendency to go towards the equator and aspirate, and you maintain the high vacuum. Most of many of the time, we don't go down much when you're finding small bits and all there. Don't you have you caught equator and pulled just like the ones which is manually pulled by catching inside the equator?
Yeah.
When you're aspirating a little bit of cortex here in the peripheral.
Yeah, yes, I think all of us have done that. But I think one very good trick, which probably I have seen Dr. Vasavada sir doing, I don't remember, but I have in one of my videos. I use generally coaxial IA. And when we are doing the cortex aspiration, the trick not to hold the capsule is pull it posteriorly and not centripetally. So if it's only a small, distance you travel with your probe, but you don't pull it centripetally, but pull it down. So what it does is that it gives fluid a chance to go underneath and the cortex get released, and you are also away from the capsule. So chances of catching hold of the capsule is quite less. So I think that avoids, whenever you are doing very fast cortex aspiration, this is what I do. So I hold the cortex and pull it down rather than centripetally.
In the second, one more thing is as Gaurav was telling about the hydration of the paracentesis. Sometimes when I do hydration, the side port gets quite white, and then you don't know exactly where you are, and you see that it is leaking again. And if you hydrate again, you don't know where the location is. And I've had 1 or 2 fluid waves going around partially. Suddenly when the fluid comes on, I stop. But then still, after it gets hydrated, and the second thing is I have stopped long back when I was PG itself. I have had detachment by pushing visco from outside the paracentesis. So at that time itself, I stopped pushing visco from a large cannula by keeping it on the outer lip of a paracentesis. Without going into the anterior chamber, I do not do that at all.
I think Dr. Naren has some question, Dr. Chitra. He was raising his hand.
Yes, Dr. Naren. Yes.
No. Just a small comment about actually the wonderful videos as usual. Just a point on that, where the DM got stuck in the cannula. I think one simple tip is you remove the tube, and then even though the the syringe doesn't fit into that hole, the assistant can just flush it along that hole. That some amount of fluid will push out the DM. That I think would really help in such scenario.
So I think next time if we have this, this was a unique situation. Luckily, the fellow held the probe just like that for at least for few minutes till we try different things. Most of the times, somebody will just pull it out and entire desmet is out with that probe. Yeah. So luckily, he didn't do that.
Can I ask a quick question, ma'am? 30 seconds.
Yeah, 30 seconds because we are really late. I have 2 sets.
Yeah, I'll finish in 10, ma'am, and leave the rest 20 to Saurabh to answer that.
Yeah.
Saurabh, one of your wonderful videos, I agree with all the panelists here. One of your cases, side port extension inadvertently that was caused due to the patient eye movement, and then you created the main incision again and largely did not use the large side port incision. Could you have used the enlarged side port incision as the main incision and not construct another main incision at all to complete the case, and yet you use the more bimanual technique? Maybe change the sleeve to a 2.81 just to fit into the extended side port incision and use that as the main bone?
Yeah, it was a quite old video, but it was very large, almost 4mm large extension. So I could not use that. I thought of that at that point, but it was also very short incision. So it would have leaked even if I had used. But yeah, if it is exactly 2.8, if I can, by mistake make it, then it was a good idea to use that.
These accidental incisions are very shallow, so difficult. It wouldn't be a proper wound construction. Thank you very much, Dr. Saurabh. And, look forward to your inputs in the next two talks. The next one is going to be on unilateral cataract. And the players here are Dr. Nivian, who's Director of the Academics of the MNI Hospital Private Limited, Chennai, and of course, a very dynamic anterior and posterior segment surgeon. And he is going to tell monofocal IOLs is the only choice in unilateral cataract. And contesting him is going to be Dr. Naren Shetty, who's a vice chairman of the Narayan Nethralaya group of hospitals, and again, a very versatile cataract surgeon. And he is going to say multifocal IOL is the option. So quite daring. So with these two, with their talks, we have an expert view to be given by none other than Dr. Binu Mathan. So let's look forward to a very interesting debate. On to you, Nivian.
Thank you, ma'am. Can you hear me?
Yes, yes.
Yeah. So respected teachers, senior ophthalmologists, my dear friends. So the topic given to me is unilateral cataracts, monofocal versus multifocal IOLs. One second. Yeah. So the presenter, that's me. I do not have any personal preference to any person, product, or the company. So what I'm going to talk about is my personal opinion. Yes, backed up by some literature and might differ from others. I know that I can't defeat Naren in two things: his charming looks and his research and theoretical knowledge about all the different types of IOLs. So I'm just going to keep it very simple and easy for all and make sure that monofocal IOLs will score over multifocal IOLs when it comes to unilateral cataract. So let me be very clear that we are not talking about operating the other eye anytime soon, or the surgeon or the patient wanting for the other eye refractive lens exchange. Because in these conditions, even my choice would be to go for a trifocal IOL, but not multifocal. So what are the various scenarios that we can have a unilateral cataract? We can have it in congenital syndromes. We can have it as secondary cataracts. We can have it trauma. We can have it during posterior subcapsular, during any steroid-induced cataracts, or pediatric cataracts, or idiopathic. So as long as congenital cataracts are concerned, I definitely prefer a monofocal IOL, because we all know they're always usually associated with some syndromes and also other comorbidities, like they have associated glaucomas, they have associated retinal problems. And we know that if you don't have a good optical system, then any of these multifocals do not work 100%. So even in the literature search, there are a lot of cases only about how to undercorrect and how to get a perfect hemotropia using monofocal IOLs, and no published articles about using multifocal IOLs in these type of cases. So the second point, in pediatric cataracts, yes, again, unilateral pediatric cataracts, there have been a lot of studies done, and we all know how the myopic shift can occur after a few years. And in conclusion, they have told, yes, I'm not going to the common side effects like glare, halos, and other things, but they also have that waxy type of a vision. And also there have been a lot of reports of explanting these multifocal IOLs in the later part of the stages of the life. So moving on to traumatic cataracts, yes, we know it can have a tone anterior capsule. As we all know, we need a good centration for any of these multifocal lenses. So when we lose the anterior capsule, we're not able to keep multifocal lenses. And all these traumatic cataracts unilateral will have some amount of zonular weakness or the irregular pupil size. And that is again going to cause distortion when it comes to pupil-dependent multifocal IOLs. And also they can have a pre-existing rupture. So you don't know the extent of the rupture. So again, here it rules out in unilateral traumatic cataracts the use of multifocal IOLs. So basically, yes, I don't have to highlight between monofocal and multifocal. Monofocal always gives you a very clear distance vision. So there is no complaint as far as the distance vision is concerned. We always go for the quality of the vision. Yes, quantity wise, we can give both 6/6, but then the quality of the vision again depends on the contrast and the amount of light loss, which is not there in monofocal IOLs. And yes, in case later on you want to do the other eye, you can always go for a small bit of myopic shift. up to 1.25. So it can have some amount of intermediate and near vision using monofocal lenses in the other eye. And whatever residual refraction is there, the patients are always happy with their glasses. But multifocal, sometimes depending on the other eye's refractive error, the patient gets confused whether they'll have to wear glasses or there's no need for wearing glasses. So in that case, again, the whole purpose of doing a multifocal uniocularly is lost. And then the neural adaptation. There's so much have been spoken about neural adaptation and so many different combinations that have been tried. But I think the recent conclusion is whatever you go for one eye, make sure the other eye also gets the same type of IOL. So yes, again, these are some of the common things with all type of multifocals, the glare, halos, loss of contrast. And it doesn't matter whether they're the advanced multifocals or the newer generation multifocals or the trifocals. In all these cases, only these symptoms are reduced, but they're not that it is not there. So these things are not there in any of the monofocal IOLs. So we all know when we have clear focal point, clear vision. So whether we do an EDOF lens or any multifocal lenses, there is a blurring of these letters because that elongated focus only gives you that 2 or 3 point focuses, and it's going to lead with glare, halos, and starburst, and so many other phenomena. And we don't want to see these type of lights when we drive or do other activities in the nighttime and low light. And in case we have something like a residual power that is left or any surgically induced astigmatism later on, and that leads to the loss of vision, it is very difficult to convince these patients who have multifocal IOLs where we have promised them very good distance and also good near vision all the time. So coming to the last scenario, in case of idiopathic unilateral cataracts, like usually between the age of 45 to 55, and they have just one eye cataract. So what could be the possibilities of the other eye? Could I either have a high or low refractive error? So patient is basically happy with the other eye vision using his glasses. So here again, the choices would be an advanced monofocal or EDOF lenses as compared to any multifocal lenses if the patient is not motivated enough to get the other eye immediately done. So basically, you just have a good target for the distance vision. As I said, eventually, if the patient again wants to do the other eye also, you can do like a micro mono vision. So then you also get some amount of intermediate and near vision. Yes, you do get surprisingly good results, and all of us have done it with monofocal IOLs like this, when reading 6.5 and 8. And again, all these things depend upon the higher order aberrations of the cornea and also all the positive spherical aberrations in these lenses. So there is various other factors and also one beautiful factor called the pseudo accommodation. So it's basically a complex phenomenon which depends on the pupil size, the against the rule cylindrical refractive error, and the multifocality of the cornea. So all these things, when you go for a monofocal, I think it's a lot safer to get your predictable results. So what will happen to these patients, 50-year-olds, which are doing 10 years later, 20 years later? I know it doesn't stay the same because as we age, the eye also ages, and then there is a shift, and then there is a loss of more vision when you have multifocal lenses, when there's severe dry eye, other corneal degenerations, or long-term any retinal pathologies that may develop due to age. So I would fail if I don't talk about the cost. Just for the completion, it's like comparing a generic shampoo against all the branded ones. So cost is also one of the effect in giving something better. And then for this, you'll have to open influences to make sure that that multifocality is working. So it is not only the lens that is doing. So you will also have to do a lot more effort to making people understand. Yes, there may be increased profits when it comes, as long as when you do a multifocal IOLs or a trifocal IOLs, but I'm sure that my moderator here doesn't go by just the cost. So once again, if you're not talking about operating the other eye and the surgeon or the patient doing the other eye, my choice would be monofocal. But then said all this, in this current era of the newer generation trifocals, and with all the lesser amount of glare and halos that it causes, and trying to give something better to the patient, I would consider the trifocals also, because I asked my friend to help me with a few points about my talk, and then he sent me a slide in which he said that use trifocals, they're slightly better. So there is an advantage when you use trifocals, I think, in the current scenarios. So I think it's good to know both sides of the coin and use it judicially, depending on what the patient wants and not what we just go for, what is the best. So in conclusion, I would say treat the patient according to what is best suited for that particular individual. Yes, we have all the publications and the guidelines, but they cannot be just followed blindly. So patient's needs is the most important key in choosing the right IOL. And it is not just what is best, what is the best IOL that is available in the market. And yes, to get the good results, we also have to go with good surgical skills and proper planning and biometry. It is not only the lens that's the everything. There are other key factors in getting the surgical technique right. And yes, quality over quantity, because we know a lot of these 6N6 patients who are unhappy, but we really don't get that many complaints when you go with a monofocal IOL. So once again, thank you, Dr. Chitra, ma'am, for this wonderful opportunity, and the Eye Foundation for this. Thank you.
Thank you. Thank you, Niven. So let's hear Dr. Naren. That was a wonderful talk, Niven.
Stop sharing.
Can you hear me, ma'am?
Yes.
All right. Thank you so much, ma'am, for the opportunity. One of the things which I was told is to defend the multifocal IOL in unilateral cataract. And so basically, if you have a scenario like this where you have unilateral cataract, and the question comes, what IOL do I implant in these cases? To answer this, it's very simple. By answering series of questions. First and foremost is, does the patient want spectacle independence most of the time? It's a simple question. And the answer also is pretty simple. Obviously, everyone would want a spectacle independence most of the time. That is, if the money is not a factor. Now, the next thing is, let's look at the literature, what actually is there in already published. So this is one of a wonderful paper published in the American Journal of Ophthalmology. Basically, they divided the unilateral cataract patients into 4 groups. The first group was where the patient was implanted a monofocal IOL. Second group was implanted accommodative IOL. Third group, diffractive multifocal IOL. And the fourth group was a refractive multifocal IOL. So when you look at the results, group 3 and 4 had higher patient satisfaction, almost about 92%, had better spectacle independence, better stereopsis, satisfactory visual, functional vision at all distances, as compared to group 1 and 2, which did not do that well. And here also, obviously, when you look at the visual acuity, definitely they do much better bilaterally in terms of, near vision, and the distance obviously is good. So the conclusion of this particular study is the unilateral implantation of multifocal IOL provides the patient with a broader range of functional vision from near to distance foci and high rates of spectacle independence and better stereopsis. And to keep in mind is, this is the older generation of multifocal. It is not even the trifocal IOL, which we are talking about, which is performs so much more better, has so much more less side effects as compared to a multifocal IOL. And obviously, there's one more study in the JS series where it's shown that, unilateral multifocal phakic patients with good functional near vision and intermediate vision and far distances, regardless of whether the phakic fellow eye is myopic, hyperopic, or ametropic. It's a very clear, a very distinct conclusion which the study has shown. There are several other papers, but the question is now we know what the patient wants. And second is, we know what that it is if at all you do any unilateral multifocal IOL implantation, patient does well. But the question is, now we have so many series of presbyopic IOLs. Really, we are in a dilemma of how to choose. So if the patient wants a presbyopic IOL, we are left with this huge array of options in the market, and really forget about the patient. The doctor itself is confused on how do we actually counsel all of this different options to the patient. To make it very simple, what I follow is just categorize into diffractive and refractive IOLs, basically refractive presbyopic IOLs. And then how does your decision making happen? So how do you choose a diffractive or a refractive IOL? Is, let's say, if a patient wants a presbyopic option, then you have to look for the diffractive IOL suitability criteria. That is, I think it's a pretty standard. First and foremost, the patient should be motivated. Most of the eye should be normal, and the rest of the scenarios. And if at all the patient is suitable for a diffractive IOL, and the patient is not a very type A personality, very high demanding patient, a very normal, has more realistic expectation, then you go ahead with the diffractive IOL. Now, if a patient is more of a type A personality, very unrealistic expectation, then simply go with a non-diffractive IOL like the VVT. And obviously, if they're not suitable for a diffractive IOL, then you go with the refractive or a non-diffractive IOL. So to conclude, what to do in a unilateral cataract, the answer is you can have a trifocal IOL as an option, provided the different scenarios and suitability criteria. If the patient is suitable, then definitely is one of a good option which the patient will be very happy with. Thank you for your time.
Thanks, Dr. Naren. That was nice. Dr. Minu, could we have your expert view?
Yeah, thank you, Dr. Chitra, for this opportunity, and well discussed, my young debaters. A lot of it has been told, but both of them have been very modest in telling that the patient comes first. And it is not we who are choosing, or we are telling that this is the option for you. So that is, I think, the most crucial part, because after getting this topic, a lady whom I had placed a multifocal, she was adamant on having no near vision glasses, but had only one eye cataract. That was around 8-9 years back. And then still she doesn't have cataract in the other eye. And still she came 2-3 weeks back, and then she was given glasses by somebody recently. And she said, "Do I need to wear this, doctor?" I said, "Do you want to wear?" She said, "No, I can see everything. I can read, I can see distance, but they gave me this for using. Should I use?" So the question is whether this patient's mindset has changed over time, or somebody has given her something or asked them to do something. So these are very important factors. We know that theoretically everything exists. Monofocal has its advantages, trifocal has it. But then if the patient is another patient came yesterday, wife of a bilateral multifocal patient. That was multifocal before our trifocals. He is still going around without, even after a yak capsulotomy, without near vision glass. She is a unilateral cataract. She came and told me, "I want only that lens. Whatever it is, I want only that husband's lens." So it is the experience of the patient and what their mindset is. If they're not motivated, or they are happy about what others are having with this kind of lenses, then if you push them, it is not going to work in many patients, because this neural adaptation thing comes last, because we have to investigate extensively, because we have seen in the previous talks in corneal part of it, the investigation part on cornea and the effective lens position and the centration and the macular issues have advanced so much that we are able to screen out more patients who, although they opt for multifocals or trifocals, are not good candidates for trifocals. So once we weed out so many the unidentified problems which are there before, and we are branding them as a adaptation issue, has come down much. So the neural adaptation happens as a last part of it, but still it is there. It is there, I agree. So monofocal, I try to tell patient that these are some of the things which you will have to expect in a multifocal, although you may most of the time have no glasses for near vision. But the other eye refraction, even this lady which I'm talking about, she has developed a 1.25 cylinder over the last 6, 8, 9 years. Still, she has 6-9 parts vision and she doesn't want to wear glasses. So, although somebody gave her glasses, and her near vision was only N8, but she's happy with that N8, and she says, "I can read everything." So again, it depends on how a patient expects things, and we know that we should know the background of how a VVT is going to function, how an Eyehance will function, and we should tell them clearly that this is going to happen. And it depends on the age, but I am not touching on the pediatric part, which is controversial, but then I would not place a multifocal on a pediatric cataract where everything is dynamically changing over a period of time, and it's very crucial to correct the visual axis or the optical axis very effectively during that developmental period. But the adult part of it, I feel that if a patient is understanding regarding his own other eye, whatever, even if other eye, whatever the refraction is, we know from their study, and we know from patients that if you give trifocal and they're happy with that eye and they don't consider the other eye at all. But there are some people who are telling that even though this eye is clear, the other eye is bothering me, and so I will definitely wear glasses. Anyway, I have to wear glasses for the other eye. I feel binocularly it should be good. Driving, it should be good. I see. I should see with both eyes. So it depends on the mindset, the type of patient, the activities of the patient, and then we choose the lens after telling them what you both of you have to talked and showed very elegantly, that these are the pros and cons of these kind of lenses. Thank you very much.
Thank you, Dr. Minu. Thanks for your thoughts.
Thank you.
Dr. Saurabh, would you think of going in for doing a clear lens extraction if the other eye has no cataract in these patients? They never brought that up. What are your thoughts?
Yeah, if the other eye has significant refractive error, then that is a very good option. Yeah. And one thing I just wanted to add in the discussion in this unilateral cataract, one thing I make sure that I talk with this patient personally and tell them not to compare the two eyes after the surgery. Because I tell them that if the other eye is either emmetrope or it's a natural clear lens, the clarity will be always better than the operated eye in most of the cases. Though EDOFs generally match the unoperated eye, but trifocal definitely they will reduce the contrast. So those patients who keep comparing the two eyes are the most unhappy patients. So you have to inform them beforehand that they will not be same. The vision will not be same in two eyes. If you are okay with that, we can go ahead with the surgery.
Thank you. Thank you very much. We shall go on to our last set of speakers, a wonderful topic, and let's all be glued to it. This is about Fuchs with early cataract. And we have Dr. Nikhil Gokhale, who heads the Gokhale Eye Hospital at Mumbai, and he's going to tell us phaco only makes sense. And Nikhil has been somebody I've had great regard and respect for over a couple of decades, and he knows about that. And I'm really happy to have him give this talk now. And the other person to contest him is going to be Dr. Praveen Krishna, who is the network director of the Technology and Communications of LV Prasad, and also the director of the Cornea Institute at LV Prasad. And he is going to tell combined procedure is the approach. And the expert view is going to be given by Dr. Namrata and this. So I would look forward to some question being answered by Dr. Shreyash or Charuta following this. And
thank you, Dr. Chitra. Yeah. Thanks, Chitra, for the opportunity. So basically, I think when we talk of Fuchs dystrophy, there is still a lot of confusing information which the general ophthalmologist would face with regard to the nomenclature. So we have a very large subset of patients who undergo cataract surgery who have guttata, and we can, just do the cataract surgery successfully and they don't progress in future. The tip of the iceberg is actually patients who have guttata which continue to progress like a Fuchs dystrophy into stromal edema and epithelial and then scarring. So this subset of patient, definitely we have to think a bit louder as to whether we are going to do just a cataract or we are going to do a triple procedure. So this is something that we have to always keep in mind. So if we have maybe 10 patients of non-progressive guttate changes in our cataract surgery patient, we may have probably less than one patient who actually has a true Fuchs dystrophy, which will progress. The next question is that are we or are our ophthalmologists well equipped to distinguish the two entities? That means whether they can distinguish whether this guttate changes is just an isolated event or it's really a Fuchs dystrophy where you're getting corneal edema. And to do that, I think we all have to learn a good slit lamp examination, do specular reflection, specular microscopy. Although, as I'll show you, it's not very often helpful, and then do a tomography and a pachymetry profile to pick up subclinical stromal edema. This is what was traditionally taught to all of us, that if you have no epithelial edema, if the pachymetry is less than 600, there's no history of morning blurring vision, just do the cataract. And patients where you have epithelial or stromal edema with significantly thick corneas and scarring, maybe you would have to do a combined surgery. Also to stress that patients where the endothelium is poor, they may be very elderly, and if the vision is acceptable, better don't do anything and just leave them alone if they can manage with their vision. And also that severe guttata can itself cause a drop in best corrected visual acuity because of scattering and glare at the posterior corneal interface. How we would see these patients or distinguish these options today is that if we have a patient, we need to analyze them, as I said earlier, and figure out if there is significant corneal edema with a clear lens, in which case you might even consider doing a endothelial keratoplasty alone. Whereas if there is a patient who has a significant corneal edema with a cataract, you might have to do basically a combined surgery. And then you have patients in between where there is no corneal edema, just guttate changes. You need to do only a cataract surgery. And for those where there is early edema, you can still do a sequential or a stage surgery. Now, what are the basic problems that we have when we say that we'll do a triple procedure or a EK, PK with a IOL? We need to understand we have only 1,000 cornea surgeons for our entire country. And if you look at the population which is aging, we have a significant volume of patients. If you look at 2022-23, about 83 lakh cataract surgeries were done. And if you consider that about 5 to 10% of this elderly population has guttate changes, so we had about 4 to 8 lakh of these patients who must have had guttate changes. We don't know how much Fuchs is, but if you in this elderly population, if you even consider to be 1%, then maybe 83% of these, 83,000 of these would have had some sort of Fuchs dystrophy changes. We need to understand that only about 28,000 transplants were done in 22-23. Many states and districts have no access to transplant surgeries, corneas, and surgeons. And throughout the country, only 4,500 EKs were done in 22-23. And we also have to understand that despite our best efforts, we can still have failures following an EK surgery. So we have plenty of patients, but we don't have enough corneas, nor we have the surgeons to handle all cases of Fuchs dystrophy. So if you are encountering a patient like this, I think we need to look at the age, vision, grade of cataract, stage of the dystrophy, surgeons' expertise, and the access to corneas. So I think the options, if you're working in a setup where there is no eye bank or there is no corneas or there are no corneal surgeons, possibly one option is to delay surgery. The other option is to do a careful cataract surgery. And the third option is, if the patient can afford, to refer him to a place where there is a good access to surgery, where they could decide whether they want to do a sequential or a simultaneous surgery. And also to say that a 618 with severe endothelial dystrophy and early cataract may be better than a hand movement due to a failed cornea in a patient who is unlikely to have an access to a transplant surgery. And that's the bitter truth in most rural areas of our country. So if the nuclear cataract is there, vision is fairly okay. One could safely defer surgery. However, if there is a dense cataract, vision is poor. One could do a phaco with a soft shell technique. However, in patient has got a very hard or a brown cataract, yeah, we can definitely do an SICS. And in those extremely complicated cases, I have no, I would often do an ECC in some of these patients, also to say that the surgeon's experience is the final guiding choice. When you do phaco, of course, you can use low flow technique, use BSS, minimize energy used, always prefer a hydrophobic IOL with a little bit of myopic target. And I still don't know the role of ROCK inhibitors, whether they really help or they don't help, we don't know. And when you're looking at stage surgery or combined surgeries, it's always, one would say that 2 surgeries, longer recovery and higher costs. However, the surgery would be technically less challenging. Although in literature, the complications are very similar overall. However, we need to understand that some of these patients in the LVP, only 10% needed a EK 1 to 2 years after cataract surgery. Whereas when you do a combined surgery, it's possibly much faster recovery. However, it could be more challenging and difficult. You could have more endothelial cell loss and more graft detachments. And we can have long-term failures over the next 10 or 15 years, which we still do not know. So I think also just a word of caution that specular microscopy is most unhelpful in these most difficult cases. And that is something we need to keep in mind whenever we evaluate these patients. So I would say assess visual loss, do relevant imaging, understand your limitations, understand the limitations the patient has, whether he can travel, whether he has access to corneas. Talk to the patient, discuss options, counsel, and sometimes masterly inaction may be a good option for some of us. But of course, if you want to do a cataract, use the safest method and the best viscoelastics. And in the very severe cases, of course, do a combined procedure. Thank you.
Thank you, Dr. Nikhil. That was a wonderful talk. So let's hear Dr. Praveen to counter him.
Hi, Nikhil, and hi, Chitra. I think, Nikhil, you spoke for both sides already, and you made the case for both approaches. So, yeah, not much of a debate. And I think at 9 p.m. on a Wednesday, I probably won't repeat a lot of the things. So I'll probably keep it really short with just a few examples about what I'm talking about. So first up, Chitra, as well as the Eye Foundation, thank you very much for having me in this webinar, as well as this interesting format. The debate format seems to be good online, so that the debaters really don't get physical. So you can say whatever you want, but remotely. So I'm going to be speaking about what happens when you have a patient with Fuchs dystrophy and cataract. And just like Nikhil spoke, I'm probably going to be speaking on both sides of the coin as well. And I'll give you some reasons for that too. So when you have somebody who has a cataract, which is greater or is causing more visual disability than the Gutay and the Fuchs dystrophy, the obvious choice is to do cataract surgery alone from the perspective of what the patient's need is. And in this case, since the primary need is a cataract surgery, that is probably what you would do. And if you have somebody with more Gutay, and there are patients even younger who don't have a significant cataract, but then who have more Gutay and more potentially corneal edema as well, you'll probably do an endothelial keratoplasty as your primary procedure. But the question here is the fact that what happens when you have both cataract as well as Gutay and Fuchs contributing to the decline in vision, and what you would potentially do here. And Nikhil did give a lot of real world scenarios as well from the perspective of tissue availability and everything else. But I'll talk in a more idealistic sense. If you have somebody with a cataract and Fuchs, you have three potential approaches. One is you can do only cataract surgery and wait for the cornea to decompensate if it ever does, and then refer to a corneal surgeon or do the DMEC surgery. The second approach, actually, which is a quite popular approach that you're not talking about today, is to do only the DMEC and not to do the cataract and wait for the cornea to clear and then do the cataract, with potentially a better refractive outcome in these cases. And the third approach, obviously, is to do a combined cataract surgery with DMEC. And we'll look at what are the upsides and downsides of each of these with some case examples. Of course, if you do a cataract surgery, you probably will worsen the Fuchs and the edema, and eventually the patient may require DMEC. And if you do a DMEC alone, you'll probably worsen the cataract, and the patient will require a cataract surgery in the future as well. So I'm going to show you about 4 cases, and each of these are diverse from the perspective of what I'm trying to show. The first one is a 62-year-old lady. Preoperatively, she didn't have any endothelial cell counts that we could obtain, but she seemed to have quite normal corneal thickness. In fact, her corneal thickness was 492, and we did a good idea to do a cataract surgery alone and not to do DMEC in this case. And so we did a cataract surgery, but a month post-cataract surgery, and it was an uneventful cataract surgery. She had significant stromal edema as well as epithelial edema, and obviously her vision was poor. And when we did the OCT, we also found that the desmoids were slightly thicker, and there were really no areas of detachment of the desmoids, though over the incisions, it seemed as if the desmoids were slightly detached. So eventually, this is a case of somebody where we did a cataract surgery in the presence of somebody who has Fuchs, and then it worsened and we required to do DMEC surgery post-operatively. That is scenario number 1. This is, on the contrary, another patient, a 59-year-old doctor, pediatrician who I've been seeing for several years, who came in with a visual acuity of 20/25 in the right eye and complained that his vision was not great. So when we did specular, like Nikhil said, the specular wasn't very useful. We couldn't get a count. But when we looked at the topography and the pachymetry on Scheimpflug, there were some of the signs that are described about loss of isopax on Scheimflug, and his thickness was 555. And then we looked at the OCT, but what was interesting in the OCT was the thickness of the Descemet's membrane was quite low. The Descemet's was quite thin, so I decided to do only a cataract surgery. And after cataract surgery, the thickness of his cornea really didn't change even 1 month after. So this probably was a good decision from the perspective of doing only a cataract surgery. I'm not going to dwell too much on literature, but again say that literature is again very diverse. It does not give any clear idea about what is a better approach. It talks about the advantages of each approach. So it seems as if what we are looking at is more of a case-to-case basis depending on what is primary. So again, I won't bore you with literature, but one of the things that is said in literature is the fact that you probably would want to separate the two procedures so that you get a better refractive outcome. But here is an example of a patient who had keratoconus with Fuchs, obviously specular, not very useful, and a relatively thick cornea. And you see that the Descemet's in this case was also very thick. And this patient, we did a Toric IOL along with a DMEC surgery in this patient. And this patient actually did really well with a Toric IOL, a very well-aligned Toric IOL. And in fact, her visual acuity in the left eye was 20 by 20 uncorrected in this eye, showing that even in cases of Fuchs dystrophy, when you're doing a DMEC, if you spend time with IOL power calculations, you can actually have very good outcomes. In the contrary, here's another patient who had Fuchs with early cataract. And after cataract surgery, post-op 3 months, she had central corneal edema. And on the OCT, she showed that there was a detached DM with a thickened DM as well. She had undergone descemetopexy twice. So instead of doing a descemetopexy, we did a DMEC. And this is again a complication of those patients where we're doing cataract surgery in patients who have Fuchs. They tend to have a higher chance of DM detachment as well. So what is the difference in these cases? And like Nikhil said, all Fuchs are not the same. And it seems as if the specular is not the best method of assessing who will need cataract surgery and who won't. And for me personally, what I follow is not the Scheimflug, but what I follow is the OCT. And on the OCT, if a patient has a thickened Descemet's membrane, and what I follow is that the Descemet's membrane is thicker than half the thickness of the epithelium, because it's difficult to measure the thickness of the Descemet's, I will do a combined surgery. If the Descemet's is thinner than half the thickness of the epithelium, about 20 microns or so, I will attempt only a cataract surgery. So again, to summarize what we've been speaking about, cataract surgery only is simple, but the problems are it's likely to need a second surgery, 2 procedures, and also the refraction is less predictable. Cataract surgery with DMEC, advantage is it's a single surgery. You can use the same incisions. The outcomes are very predictable. But the downside is there is a slightly higher endothelial cell loss after you do a combined surgery rather than sequential surgery. So what I follow right now is, again, I won't go into literature, is if I have a patient who has cataract, which is slightly more than the Fuchs, and the Descemet's membrane thickness is normal, then I would do only a cataract surgery. If the same patient has a thick Descemet's membrane, then I would do a cataract surgery with DMEC. On the other hand, if I have somebody where the Fuchs or the edema or the gutte is more than the cataract, and if the patient is young, then I would do only a DMEC and not do the cataract. If the patient is older, where I would think that he probably will develop a cataract soon or doesn't need accommodation, I'll do a cataract surgery and DMEC. Most other cases where the cataract is equal to the Fuchs, like I said again, I will look at the OCT, but in most cases, I will probably do a combined surgery for the reasons that I mentioned earlier. Thank you very much for your kind attention.
Thanks, Dr. Praveen. The talk was brilliant, and really look forward to what Namrata has to add.
I think I have very little to add. Both of the debaters were so elegant, so astute, and so decent that, none actually debated each other. And the topic is also like this, which is debatable, but still has some, guidelines. So I think whenever there's a case of cataract and Fuchs both, as is rightly said, One thing is more important, that is the visualization. How is the visibility, whether you can do cataract alone or not. One point which was mentioned very well by Dr. Praveen, and I'm happy to note this parameter, that you compare the Descemet membrane thickness with the epithelial thickness, and then accordingly you decide whether you would want to do a combined procedure or not. Having said this, if there is a cataract with a Fuchs dystrophy, and if you ever think that you have to do a DMEC, and even if there is very early cataract, I would rather do a combined procedure, because obviously after doing a DMEC graft, you don't want to do a sequential cataract surgery, because you will lose some amount of endothelial cells on the DMEC graft that are there. Another important entity, which I think, I have also seen, and I'm glad that Praveen brought it out, was seen a lot of these cases of keratoconus which have, Fuchs dystrophy, or which have Gutte. I don't know whether to call them Fuchs dystrophy or not. And there's a whole series now which we are about to publish. And this is a reality, that many of the ectasias that you have would have, those Gutte which are present. Of course, the Sanjay Patel's paper, which has been quoted about the loss of isopax in early Fuchs is there, but I don't think that really can be an indicator, or that really can give you a clue on what surgery you have to plan. So essentially, the parameters which will decide whether you have to do a single stage surgery or sequential surgery would be the visibility that you have, how much you can visualize. Also would be the morphology of the Descemet's membrane in terms of thickness, in terms of presence of Gutte, in terms of sometimes the Descemet's membrane is thick and sometimes it is absolutely fibrosed. And I think one thing that has not been touched is DVEC with, phacoemulsification. I don't know, there are not very many studies present, but I'm sure that DVEC, that means the Descemet's, just stripping, or DSO, Descemet's stripping, just stripping the Descemet's membrane and not doing a graft, plus doing a phaco and IOL would be equal to, what we do DVEC or DSO alone for a Fuchs dystrophy, and allow the cells to populate from the periphery into the center. So that is something which may be tried by people in future. But I think otherwise, all the points have been really covered very well, and there's nothing actually left to discuss.
Two questions I have to all the cornea people here. If a patient with early Fuchs has, not early Fuchs, could be progressive, has high astigmatism, would you put a toric IOL in this patient? Because later there is going to be a possibility of doing an endothelial keratoplasty, and the things can change, right? Dr. Praveen had shown one video where he did a toric IOL in a cataract patient.
Yeah, I've done, and I think we've had several cases where patients have had toric IOLs done before in normal eyes, then they had TAS or PBK because of other reasons, even multifocal IOLs, actually EDOFs. And after that, we've been able to do DMEC or DSEC. And I must say that with DMEC at least, and if they're done early enough, then the results are almost the same as you would do for any patient with a normal cataract. So I don't think the potential for undergoing an endothelial keratoplasty needs to exclude them from any toric lens, especially. Premium lens, I wouldn't say yes, because in the presence of Gutte, there are more variables with astigmatism and all that. But I think toric IOL at least for sure.
Is there a specific specular count, endothelial count at which you would decide to make a transition, or pachymetry is a more important guide?
No, I think pachymetry probably is the more important. Pachymetry and OCT seem to be the better guide to decide on combined versus single.
I think this was shown also. Nikhil showed pachymetry of 640.
Yes.
The magic figure, and for endothelial cell count, it is generally said less than 500, but we've seen at 500 also the corneas remaining clear. So that is why specular is not, that sacrosanct. And given the fact that specular microscopy can be erroneous, it may pick up from areas, which are not uniformly having a diseased endothelium.
There is a variant of Fuchs dystrophy where you don't get much gutted changes. You just start getting big cells and the cell density keeps dropping. In some of these patients, like I have seen them, encountered them by chance when the other eye, somebody referred for a bullous keratopathy, and then you do the specular and you suddenly find the cornea looks clear, just like a graft with 500 cells looks absolutely clear. These corneas look clear, but when you do the cell density, it's pretty low. So in this variant of the dystrophy, maybe the specular count might guide, but in patients where there are large areas of gutted changes, the cell morphology may not be reliable enough.
Thank you. Thank you. I think it goes without saying that the debates were wonderful right from the beginning till the end, the discussions and the expert views. So I'm truly grateful to the experts for having been there and given the very right views, and the debaters were just unimaginably good. So it truly made my day that this webinar for the Eye Foundation was a hit, but it couldn't have happened without all of you on the expert panel and the great set of speakers. Thank you so much. I was so sure I'll do it in 2 hours, but the topics are so good that I let it drag on. Thank you so much.
Thank you, Chitra. Thank you. I think it is.
Thank you, ma'am. Thank you, sir.
Wonderful set of speakers and very good topics. Very good topics.
Thank you. Thank you, everyone. Thank you very much.
Thank you for conducting, ma'am. Thanks, everyone.
Thank you. Thank you.
Thank you.
Bye-bye.
Thank you so much. Bye-bye.
Thank you.